Good morning and welcome to the Health Board and our meeting for today. We have a number of guests who are going to be joining us in person and in Teams, and welcome to those who are from the general public who are observing us today. It's nice to know that you're with us. I'd like to welcome Andy Bagwell, who's Deputy Medical Director in place of James, who's unable to be here, and Linda, I can't see, only for the items. Linda Joseph, the Deputy Regional Director of FLICE, will join us for her item. We have a number of guests who will be coming in and out, and I'll invite them to say who they are when we get to their item. Welcome. Yep. So we have apologies for absence for noting from James, from Leanne Watkins, Chief Operating Officer, and Martin Blakesher, one of our independent. Are there any declarations of interest for noting before we start, please? Robert, could you just go around the corner because I can't see you at all? Yeah. Thank you. The draft meetings, the draft minutes of the meeting on the 27th of September are in front of you for approval. Are they a correct record? Any amendments? No. And we also have under 1.5 a summary of board business held in committee during September and October for noting. Any comments on those? We will, be, of course, be returning to those topics today. The board action log for review, please, Rani.
Thanks, Chair. So the action log includes 8 actions from previous meetings. 7 are marked as complete with updates provided within the paper. And there is 1 action that remains outstanding in respect of CHC commissioning, and that is scheduled to come back to the board in July. Thank you.
Any comments or questions? No. 1.7. The report on sealed documents and Chair's actions, Rani.
Thanks, Chair. So this paper summarises the use of Chair's action and the application of the common seal between the 7th of September and the 31st of October. There have been 5 applications of the seal used as outlined within the paper, and 1 contract has been awarded under Chair's action, which is also summarised within the paper for the board's ratification.
Are you happy to ratify that decision?
I'm happy to, but under the last item on the renewal of the lease, I'm just interested to know, because it's an industrial estate, just wondered what do we have in Virgin that we're having to renew a lease on? And also I'm assuming with all these renewals of leases, bearing in mind we're looking to, this is part of a programme, so we're not entering into another 10-year lease or whatever it is.
Yeah, I'll need to confirm for sure, but I think it's related to the 111 programme.
Yeah,
it's right, isn't it? It's the 111. It's We Just Host it, which is currently under discussion to be transferred from the Health Board as a host. Yeah. So we won't have those issues going on.
Yes. Okay. Any further questions? We're happy to adopt those. Fine, thank you. Report from the Chair. In addition to the usual meetings that seem to fill my entire life, we've had 3 meetings of the Regional Partnership Board in the last few months, one of which was a workshop to review the strategy, which was very important, and as many of the RPB members are new and therefore had not been party to the establishment of the strategy in the first instance, and of course the population needs have changed as well since that was established. So that was quite helpful in resetting the parameters for a strategy for the Regional Partnership Board, which, when it's drafted out again, will be brought back here, obviously, for adoption as part of that partnership. We also continued the discussion on the governance review, and there is a great deal of activity taking place in terms of revising the governance of the organisation. Well, it's not an organisation, it's a partnership, and that was one of the problems, as its responsibilities have extended incredibly over the past few years, and the governance really was no longer fit for purpose. So We've had an independent review, as you know, and we're now taking forward the recommendations of that review, put them into practical reality. Tanya Evans, the Director of Social Services in Blaenau Gwent, is leading that piece of work, and Phil is on for us because of the expanding of local government as well as the health board, and that's making progress. We also agreed the strategy underpinning the capital programme, and we were commended, I understand, Hannah, by Welsh Government this week on the quality of that, which is good. Very good. No one says things like that, but that was good. And now it's being translated into what this capital programme actually looks like and what it's there to achieve. So that's well on its way now, after a bit of a funny start. Yeah. There have also been two meetings of the chairs group, and as you can imagine, these have not been very jolly meetings. We have been looking very seriously at the finance and service delivery issues facing each one of the health boards and the work being undertaken by the other health bodies in support and to act as a complement to the work that we're doing. We are liaising exceptionally closely with the chief executives, and the chief executives representative comes to each of our meetings. And we had a meeting yesterday, and Paul was quite clear about the synergy that has to operate between the chairs and the chief executives in facing some of these major issues. The chairs have agreed a draft letter to go to the minister, explaining what we are collectively as organisations trying to do in terms to balance our books and to maintain and improve our services. It's not an easy feat, I have to say. But nevertheless, it has outlined how we're going about it, what the ethical frameworks are that we're using, and also how we are how we are taking that forward for the future. And we have, of course, been discussing the revised committee structures in health boards, particularly those affecting Wisk and Esk, as there has been a review into the functionality of those subcommittees of health boards. Progress is being made, being led by Welsh Government. This new committee structure has to be in place by April, and we are trying very hard to ensure that the governance of the subcommittee fits well with the aspirations and the governance of the health boards to whom they are responsible. Rani's doing a super piece of work leading the governance work stream in that respect, and is reaching an accommodation and agreement amongst the governance work stream, so that we feel we are solid in terms of it fitting well with our organisation and its structures. There is also a view that when we settle down the subcommittee structure, we will then take a review into the appropriateness of some of the services that are now being commissioned, as many of them over the years, because they haven't been looked at for some years, are now really straightforward secondary care services for which we could commission ourselves. So that review will be undertaken. I had the great pleasure of attending the opening of Asa House in Blaenau Gwent, which is a new joint venture between the Housing Association, ourselves, and the RPB to establish a home of safety for up to 5 young people who have just come out of the care system, to enable them to settle before moving in about up to 2 years into their own accommodation. It's the most beautiful facility, and we were really, Hannah came with me, we were really pleased that one of the new residents took us round and was able to explain. Actually, I think she'd only been there 2 weeks,
Yeah.
but she was well settled in and is actually an exceptionally good cook, I have to say. But she said she was really, really happy. I don't know how many times she'd moved in her very young life because she was only 18, but about 30 times.
Yeah.
Something like that. She'd been moved dreadfully, dreadful experience, I'm sure. But she said she was really happy, really had settled and really taken over the place, I have to say, but felt really, really safe. And so, you know, that is a joint venture that's made such a difference to individuals, and they've been well received by the neighbours, and it is indeed beautiful. So I would recommend anybody go and see it. It's lovely. I also went up to Neville Hall to review progress up there, and was very pleased to see that it was bustling and about its business as we would expect. I haven't been out as much as I would have wished, and it's just due to time constraints at the moment. Everything's terribly busy, as you can imagine. I've also chaired 2 meetings of the Minister's Accountability Meeting, advisory group on governance in the NHS. We have decided on our plan for gathering evidence, and one of the plans for gathering evidence is to interview each health board separately, so that we can get a view on the governance and the way in which you would wish us to approach it. There are a number of key questions which will be circulated to all health bodies that we would like you to concentrate on, but they basically involve the strengths and weaknesses of the current governance systems and how do they compare to England and Scotland and Ireland, and are their structures effective and how do they know? What sort of national leadership do we need in Wales and how can it be delivered? What are the current elements of performance management and improvement, and are they effective? And the anomalies in that system. And really, what's the culture that should be generated in order to provide levers for change and improve performance and delivery? So those are the sorts of things that they will be looking at. It's quite a wide-ranging group of individuals that we have on that advisory board, with whom it's very interesting to work. But we haven't got much time to do any of this. We will have a number of bilateral meetings with members of the opposition, ministers, First Minister, and key stakeholders, including CLICE, and then draw evidence from expert bodies and hold a seminar to try and reach a conclusion on that. But the advice and guidance to be given by health boards is going to be critically important. And it's all going on, and the Minister's keeping a very watchful eye on it, I have to say. So that's what I've been up to. Are there any questions? No? You? Nicola.
Yeah, thanks, Chair. So, so it's been a continued busy few months, as you can imagine, and really trying to, continue to focus on priorities and the delivery against those and preparing for winter. I think we all worried about, the challenges we face in winter, facing us, and we know last year was particularly challenges. So we really are trying to learn from that to make sure we got proper preparation for winter. And a continued relentless focus on the financial challenge, which you'll be all aware of. It's probably appropriate to acknowledge the allocation of £88 million for this health board. I don't think it can be underestimated the significant efforts of NHS Wales and the discussions with government to secure that additional funding, a large proportion of which is some of it's not, but it doesn't address all of our financial challenge. We've still got a significant shortfall against which we expected to deliver, and we'll pick that up later on the financial agenda. But what I think it does do is on the optimistic side, the ability to recover from this on a sustainable basis over the next few years now doesn't feel quite as impossible as it did when we were without that funding. So I think it does give us a bit more hope for the future and kind of think about our sustainability plans. So as I mentioned, preparing for winter, we've already seen, I think, in the last few weeks, the start of that extra demand, that acuity coming through the door. Urgent care continues to be one of the key concerns for us as an executive team in terms of the pressure, not just the numbers next you don't present, but the acuity that often presents at that front end of the system. There's been a continued focus on the discharges, working with local authority, and Jen through the Discharge Improvement Board with her colleagues, and Andy's been involved as well, where we've had a series of patient safety events focusing on one site and really pulling all partners together to look at how we can unlock some of the discharges and get people home where appropriate to do so. So there's been a huge success in some of those, and we're now looking at how we can almost, make those a routine event through the winter as one of our key actions, rather than once every couple of 6 months we try to do that focused effort. So we really are, and again, to the point where you can see it becoming much more systematic and embedded. So the patient safety events have been really helpful, and also helping us understand what some of those blockages are and what some of those issues that we really need to unlock. The local authorities, third sector, being absolutely central to that with us as well. We've, at the last board meeting, we recently got performance and accountability framework. We've spent the last few months doing our mid-year divisional reviews, which are quite a standard approach, but they're now very clear, they sit within that framework. We've got one division left to meet. And alongside that, we've also 7 of our divisions on the back of that framework are in an enhanced monitoring around the finances. So we've been enacting that framework. And we had a bit of a mammoth day where we met every one of those divisions with a deep dive on finance. And between the divisional reviews and the finance, it really is helpful to get underneath, the achievements the divisions have made, the challenges they face and the risks they've got, and really make sure we are supporting them where we can, challenging where appropriate. But what it does, it does really hit home is, the competing priorities of the operational teams in trying to juggle the workforce challenges, the financial challenge, and that operational delivery of key priorities. But, huge amounts of work from the division and on it. Personally thank them for the amount, all the work they do in, and trying to keep them going is pretty essential for us in terms of our delivery programme. In terms of going out and about, it was really great. We opened the endoscopy unit. It's great when you see these big capital programmes actually come to life. So opened the new endoscopy unit, and the team are absolutely thrilled with the unit. It opened with pretty, only a few little issues, nothing major, but they've worked relentlessly, and you can see the effort and the hours they put into it as a team, and really proud of the unit, with lots more potential to use that. So that was really great. Also went up to see the YWF team were preparing for the stroke centralisation, which we'll come on to later. But huge efforts in terms of trying to reconfigure wards and look at how we're going to bring teams together there. But lots of energy, and everyone really committed that this is the right thing to do. And I also had the pleasure of kind of speaking at the Hospice of the Valleys AGM, and really reinforces just that kind of power working with the third sector and what they can offer us alongside our services. So that was really good as well. And then there was about over a period of 2 weeks out, there was the nursing conference, which is the first in-person nursing conference since COVID that we've done. It was a fantastic event, and the energy in the room in these type of events is you can't describe it really, but really kind of inspirational, and speaking to the nurses after, feel really motivated on the back of that. And there's also been the leading the midwifery and nursing leadership programme, where Anne and I we attended that, and I also the week before attended the leading people programme. And my reflections from it is, the value that staff get out of having that time out of their day job, having time to develop, to think and meet other people, build relationships around the organisation, connecting themselves, which they otherwise wouldn't, is just, you can see the energy and the motivation that comes out of that. And I think it's something we've really got to hold on to and build on, because I think it's really valued, and, has so much positive outcomes as a result of it. And then finally, the NHS Awards held last week virtually rather than in person, unfortunately, because of the kind of context we're working in. We had 6 nominations in the 6 finalists that were in the, we brought them all in the room together to put them in mutual support, and we had 2 winners across 3 awards. So we had a patient story at the board. It was the co-production working with parents on the neurodevelopmental service. They won their category, and Sarah's team, all the work we've been doing on employee relations and the investigations who won his category, but also won the overall Outstanding Achievement Award, which was quite unique, really, in terms of a corporate type service winning the overall NHS award. So the team were speechless, really, and in shock in the room, but really great to get the recognition of the work they've done and see how it benefits all staff and getting that bit right. So that's all I was going to cover. We pick up lots of those issues as we work through the agenda. Thank you.
Thank you, Nicola, and thank you very much to both you and the executive team for the really hard and difficult work that you've had to be doing in this period, which is already busy enough. So we're grateful for the response that we've had from you all. Are there any questions, Nicola? No? Shall we move on to Linda and the report from FICE, please? Linda?
Good morning, everybody. Thanks for letting me speak at the meeting. Thank you, Chair. Yes, the meeting that we've we've actually sent you the report from FICE, and we've provided a overview of our transition from CHC to FICE through our 100-day plan. We've provided information covering the period for the 1st of September to the 31st of October. And in that, we've talked about the public feedback from our advocacy service. And in terms of NHS concerns, we've received 57 contacts from people. 15 of those were general inquiries about waiting times for test results, operations, and for ENT appointments. There were concerns expressed about hospital transport and the discharge and transfer from hospitals. Of those 57 contacts, we've had 37 consent forms sent back to pursue a formal complaint. The services and subjects of concerns have been rather mixed, but they include the care of the elderly, primary care, adult mental health services, and waiting times for surgery and appointments. Moving on to the representation section, we've been very busy. We've been involved in and made representations across a wide range of services, and a full list is presented in this report. I won't go through that whole list because it's quite lengthy, but if anyone wants more information about anything in the list, I'm more than happy to take questions either here or after the meeting, and I'll be happy to discuss those issues further. Moving on quickly to engagement. FICE has been involved in a wide range of events during the summer across Gwent and more recently. We are very conscious that we really need to promote FICE as it's still a relatively new organisation. So we've decided that we will carry out a programme of community engagement, and that will include things like visits to libraries, community centres, supermarkets, all that sort of thing, to promote the new organisation so that people understand what we're doing, what our new name is, what it means, and to really promote ourselves. We've got a suite of publicity materials at our disposal, and we've contacted the relevant services to see if they can display those materials on our behalf. If there are any questions about the report, then fire away. Thank you.
Are there any questions? Paul?
Thank you very much, Linda, for the report. It's very helpful. I just wondered if at some point you could focus on a report on children and young people agenda. I think that's particularly sort of come to the forefront, and I just wondered, in lots of the sort of materials in the media, and I just wondered if as part of your programme you were considering some aspects of that, or what you intended to do with regard to children and young people and the their views on health and social care?
Yes, we're developing a project around children and young people. I'm sure you can appreciate we're quite new to social care issues, so we're having to tread a bit more carefully in the way that we approach that. And I understand we're having some training around children and young people, particularly in relation to social care. So the kinds of things that we're looking at is ways of engaging with our younger population to find out what their concerns and issues might be, and then we can build a strategy around that.
That's helpful. Thank you very much.
That's okay.
Ewan?
Yeah, just wondering, as you say, we've been about 100 days now running with this, and every report we pick up a number of formal complaints that have been raised with us. Is there a mechanism for feedback on what the outcomes of those complaints are? If that's a question for us or Fleischroom.
Well,
So-
yes, sorry.
Go on, Linda.
In terms of lice, people can obviously complain to us about whatever issues are concerning them. There's a formal process that they have to go through. They have to give consent for us to act on their behalf so that our advocates can investigate the problems and help them with their complaint. There's the putting things right process that the health board offers as well. In the early stages of a concern being raised, it may be that one of our advocates would, or myself, would contact the health board or the social care service to see what can be done, you know, as quickly as possible for the person. If it's something rather more complex or serious, then we would have to put in a formal complaint on behalf of that particular person who's making the complaint, and that would go to the health board. If then they are still not sufficiently pleased with what they've heard or content that their issues being dealt with, then Fleiss can advocate for them and take their complaint further to the Public Service Ombudsman. Then any sort of reaction from the Public Service Ombudsman would be fed back to the client, and any feedback from the health board or social care would similarly be reported back to the client.
Sorry, my question obviously came across the wrong way. It's not so much what we're doing in collecting the complaints, it's the feedback to the board, because we get we took there are 37 complaints, but what is the outcome of those?
So,
Yes.
so any complaints that come to us, Ewan, are clearly, we go through the process that sits within Welsh Government policy. But what we do is provide the learning. That learning is reported through PQSOC. So each meeting.
What for the full board? Because this has been raised up to us now in terms of, I think it was 25 the time before that, those 29, 37. So there's a lot of complaints being reported to us as a complete board.
So it'll also form part of the quality report that you'll see later in the agenda. But clearly the mechanism we go through is through PQSOC, through to now the quality reporting that you'll get on board that we've got.
Yes, just to add, I suppose. So they are the complaints that come through Fleiss.
Yeah.
Obviously, have a lot more that come direct to us. So 25 and 37 is.
Oh yeah, I appreciate this. Yeah, this is a small proportion, but there's nothing on this report that says what the outcome was of those.
I think that's part of Fleiss complaints, plus all that come direct to us. What are the themes? What's the learning? What are we doing about it? And that's the work that Jen's team, and again, we're trying to strengthen that thematic review and the learning. And I still personally sign all the complaints. The timing sometimes, but you can, and Jen does review to make sure we are picking up those themes, and the team do that, because there'll be isolated incidents, but you can pick up themes, and that's some of our work we've done around escalating issues has been as a result of the things that we see through that complaint.
Yeah, given the current climate out there, it's making sure that we're addressing.
Yeah.
There is a free flow.
And what we have demonstrated in some of the data stated is more work we're doing on early resolution. And the panels team talked about the patient liaison is about trying to support people when they're experiencing the issue, rather than wait until they're really disappointed and then send a complaint. So we're trying to do much more, on the on the case kind of resolution and aid resolution, which is starting to show dividends, I think, Jen, but lots more to do.
Are there any further queries or questions? Linda, you've very helpfully given us a list of your intervention and involvement in our services. Do you have a similar list for social services?
Not at this stage, no, because we're still going through quite a bit of learning on that. We have had some events around social services, but it's proving to be much slower than it is without, you know, developed work with the health board. So I would say we're still in the early stages of building our relationships with the local authorities. We're also involved in the regional partnership board work. So I think it's a case of watch this space at the moment on social care. We were never in a position to be able to just sort of leap into social care. You know, it's a different set of players in that, and in some respects, it's a more sensitive area in a lot of ways. So it's been a question of trying to work with the information that we've got, but also being mindful of the sensitivities around social care. So, for instance, the initial thought was, well, we'll just carry on what we're doing with the NHS and we'll just transfer it into social care. Well, you know, clearly that wasn't going to be the right approach for that. It's further complicated by the fact, for instance, that if we get information about nursing homes or care homes, that they're by and large privately run. So therefore, we have to work collaboratively with them as individual privately owned establishments, so that we can engage with them in an appropriate manner. We don't have the right to just walk in and, you know, do surveys. So we've had to sort of work around that and say, well, you know, obviously that a care home is somebody's home. So we can't actually just walk into there. We need to negotiate how we're going to access the people that we need to speak to. So those are the kinds of things that we're going through at the moment. But rest assured that, you know, when we do get social care responses in, and to be fair, they have been dealt with very quickly by the local authorities. So it's often the case that we don't need to go through the formal concern process, that it can be dealt with fairly quickly and fairly locally. Is that helpful?
Pippa?
Thank you, and thanks, Linda. Just something a little bit more on that. I think as a health board, we're quite interested in that kind of pathway that people have. So that kind of junction between health and social, where it becomes part of the same journey for people. I mean, you know, somebody who leaves hospital and receives social care, it's part of their journey. And so I think it might be helpful to for Llais to be listening to what that feels like to people. And just briefly on your last point on with care homes, it might be worth you just touching base with Care Inspector at Wales, because that's an area where they've got a lot of experience. And so as an organisation, you may just find it helpful to have a chat with them.
Yeah, we are already in discussions with Care in Wales, and it's we've got a very good relationship with HIW, but we haven't had such a strong relationship with CIW. So that's in hand at a national level. And locally, we've formed relationships with the 5 local authorities, the social services directors. We meet up with them once a quarter. And it is a learning experience for us in terms of the pathway and journey from the NHS to social care. The major issue in that, excuse me, and I've got personal experience of this, is the problems with getting support at home once you've left hospital or left the care system. It's been an issue for many decades, and it remains so. But I know that there are mechanisms in place now where the health board and the local authorities are working more closely together through the regional partnership to address these issues. And LICE is involved in those discussions. So, you know, I'm hopeful that the transition from the NHS to the social care system will be rather more seamless than it has been.
Thank you. So do we all, including the patients, I'm sure.
Yeah.
Thank you very much, Linda. Any further comments or questions to Linda? Thank you.
Thank you, Chair.
Look forward to seeing you soon.
Thank you, Anne.
Thank you. Can we move to 2.2, the patient story, and Tulare Ward, CRT, and welcome, Caroline and Chloe.
Trying my best to see
You carry on wherever you feel comfy.
sounds like it's an hour, right?
Hi.
You know, we're very proud of our nurses, and Zoe and Caroline have been doing some fantastic work on Tulare Ward around in nurse level.
Yeah.
Well, obviously we're here to talk about the nurse-led model at Aneurin Bevan. I'm Caroline Morgan, I'm the senior nurse, lucky to be the senior nurse. And this is Zoe. Zoe's the clinical lead for the nurse practitioners in Blaenau and Gwent. Not as scary faces, aren't we, right? So
We're all big fans now, carry on.
Thank you. So a little bit of background as to how we got Tulare Ward to become a nurse-led ward was one of the biggest drivers was the difficulty in recruiting back in 2016 medical staffing, which meant we needed to look at I wasn't there, but they needed to look at alternative options of care delivery needed to be explored. These needed to be deliverable by the available workforce and at least meet and ideally exceed the needs of the people that were needed our care and support in Blaenau and Gwent. The data showed the acuity of the patients that we had in the hospital could fitted really well with the nurse practitioner's scope of practice, and hence Tulare Ward was born as a 24-bedded unit initially, looking at, it was multidisciplinary approach to discharge. It was developed in line with ABUHB's graduated care approach, and the aim was to wrap our patients around by providing the right care to the right patients at the right time. The development of the new model was facilitated and made possible by that. Can I pop on to the next one? Sorry. The aims of the model were to ensure care was delivered as close to home as possible, to ensure there was a holistic approach. A big part was to empower and progress the advanced nurse practice, which we felt we needed. It was in its infancy really, and we needed to push and develop that. How we operate is with a step down, step across approach. So the patients come from into hospital from the other 2 wards that we have on site or from the ELGHs to fit the criteria for the nurse-led ward. There is specific criteria set for that. Another primary aim, and probably the one, a big one for me and what I've been part of since I've been there, is to incorporate succession planning by means of growing our own workforce and to ensure that we've got a sustainable model. The model that it's been successfully was implemented, sustained and developed in the last 7 years. When we started, we had Zoe, or when they started, they had Zoe. So they had Zoe, who was not an advanced she wasn't an advanced nurse practitioner at that stage. She was a nurse practitioner on a master's pathway. We now have 2 advanced nurse practitioners who are fully fledged. We've got a nurse practitioner who's just waiting to complete her portfolio, so we're hopeful in the next 6 months or so she'll also be advanced status. We've got 2 academy nurses that are nearing the completion of their academic study, and we've got 1 on the master's pathway. So I think from going from 1 nurse practitioner to that is a feat in itself. So the successes for us then is that we've operated for 7 years successfully and grown. We've we've developed the advanced nurse practitioners, but we're also looking at the rest of the workforce. So we're looking at the unregistered team. So as well as looking at our band 7s, we're also looking at band 4s, and we're looking at how we can develop our healthcare support workers as well, so that there's a clear pathway for everybody. It's improved our discharge and our length of stay. So when I first opened, the data we had from pre-COVID was 25 to 16 days was the average length of stay. And improved collaborative working within the community. It was very much a team approach between all of the wards, whereas I think previously they've been very silo in their working. It was one hospital, 3 wards, but never the trained of mate. We're hoping it'll pave the way for across the health board, because it's been a model that has worked in Yab, and there's no reason it couldn't work for other wards for us and within the community hospital setting at least. And there's been lots of positive patient and family feedback from the model as well. Over to Zoe.
Thanks, Sophie. So in Yab on Tulare, well, there's 2 models. The first is the one Caroline spoke about, which started 7 years ago. And then there's a 32-bedded ward, and we needed to think, what can we do with the other beds? At the time, there was a bit of surge capacity, but obviously recruitment and things, we needed to look at how else can we benefit Gwent patients. So we looked at our community resource team. So our community resource team is the rapid response team, you might use as, of a team in the community of consultant, doctors, AMP, physician associate, mental health, pharmacists, respiratory team. Don't leave anyone out because they're all an amazing team. So fundamentally, their aim is to keep patients where they should be, at home. But we also know that not just in Blaen y Gwent, but in all areas, there's some patients that require hospital admission. Now, that doesn't mean they need to go to the Grange or our LGHs. That just means they need some acute medical care that could be managed in our community sectors. So we've always had some DAC beds, or direct admission beds, on each site, but we looked at, can we revamp this to a bigger model? Can we do a little bit bigger? Can we go big or go home, isn't it? So we looked at stepping the patients up into acute sector. Into acute sector, avoid acute, come into the community. And we looked at a short stay solution. So we operate on fundamentally a 5-day stay and trying to turn the patients around. We know that patients need conditions if they're in a hospital a lot longer. So the sooner we can get patients in, treated and back into their environment, that will help to prevent deconditioning. But again, these are individuals, these are patients. 5 days don't work for all. Some need a couple more days that we can manage within the unit, and some need less. But we do try to operate around our 5 days. So there's 8 beds within our unit on the nurse-led ward that are operated and managed through the CR team in region coming in to see these patients. So we've got 7 beds. Some are operated not just for a rapid response, but we've also got our reablement team. Within the reablement team, then they try to rehab patients and pull them back into the community with our OTs, physio. So we work very collaboratively within the community and integrated. And then we obviously got the beds for the admission for the rapid response. And we also have 1 bed, which I do love the use of this bed. It's our ambulatory bed or hot clinic. We have patients that come in for blood transfusions, bone protections, iron infusions, clinics. They would normally, we've got 1 that comes in every 3 weeks. She was going down to St. Bullis, hers up till then, now coming back into the, in her own community, into Yab. Therefore, then she doesn't have to be resourcing onto ambulance service. Family can bring her because it's 10 minutes up the road. So that's, we found is a very good service. We can then support the nuclear sector and also support our patients within Blaen y Gwent that are struggling to access the wider services within the health board. Next slide, please. So there was a lot of drives for this change. It was in development with the clinical futures and care closer to home. We want patients to stay at home ultimately, but as I said, you know, where they can be met, and that for them would be in Edinvale Hospital, which is the closest area within the Blaen y Gwent sector. We had to look at our patients that were there. For a lot of complex elderly patients that needed that support, and what was it that they required and what help. We was looking at working collaboratively. It's not just the CR team that's involved in this, it's everybody. We work with the whole of the community sectors, WAST as well, to get this to run. CRT and Blaen y Gwent changed a lot over the last year or two on how they work. We still manage our patients, but we needed to create capacity for referrals, to come in from all areas. So we've developed the workforce, put advanced nurse practitioners in there to be able to see more patients, to support the doctors to do the jobs that they need to do as well. So the processes, it would be, years ago, it would just be a GP that referred into Rapid. We changed that. We felt anyone that had a registration would be able to make an assessment. So if a district nurse went out seeing a patient that needed support, they can refer in. Our hospice of the Valleys, actually, just before I came in, they're utilising a bed today for a patient that requires some fluids for the next 24, 48 hours. So they have utilised the bed. And we're also a CRT team. Patients that they're in with, they need some support with care needs or equipment, but that needs to go in and they're not safe to remain in our environment. So they'll come into a short stay unit while everything's changed around, maybe equipment's ordered, etc. It could be 24 hours or less, but it's trying to make sure that that care is wrapped around the patients. We all know we do try our hardest to get patients right when we discharge them, but when they get home, then we see things might not be quite right. They can come in, re-look at that care needs, and then obviously back out to the community to re-look at that. And then that would prevent going to the acutes, which obviously then we don't want that to happen because we want to try to keep them conditioned in a big part. So they'll ring through to our CRT team. They ring through, they'll speak to an advanced nurse practitioner or a doctor on the end of the phone. They'll screen the process and the referral, and then they'll decide if they're appropriate. That doesn't mean they automatically get an entry to the bed. Again, we go out and see, can we keep this patient at home? What do we need? Who do we need to contact? Do we need carers? Do we need other to service that patient at home? And if not, then we arrange them to come in. Now, one thing I was really surprised at is a lot of patients, when we say you've got a bed in Yab, they can get their own way into hospital because it's not far up the road. So that was quite a shock to us. Although WAST has been phenomenal, we give our flow centre a ring and they admit the patients. The bed's ready for them, so it's quicker for them to come in, bring the patient in, and then they're on their way again and we take over that care. But I was surprised there was a lot of patients coming in, and then obviously they're got that bed ready for that family member. The stress for the family, they can come in and see them. They got their long visiting hours, which helps them to improve that support to wrap around them. Multidisciplinary, which we spoke about, to stay in their discharge. We've got the wraparound service. We've got in-reaching from community resource team, which is our OT, physios and carers in the community that come in to see these patients and try to pull them back out into the community. So that works really well, especially the patients that are anxious to get to see who they're going to meet in the community. Our aim is obviously to get them back into the community. Some patients come in, have treatment and discharge back to the GP. The majority of our patients are followed up even just once on discharge, just to make sure there's no concerns, and then they're discharged back to GP, and others stay with us for a little longer just to continue their care needs. As soon as they're medically optimised to be discharged, a lot of the care, even antibiotics, IVs, can be given in the community, so we'll continue that in their own home, which patients prefer. If we're unable to do that, we'll see on the next slide, there isn't many, but if we are unable, we try not to use the acute. We try to use our medical wards that we have on the other two wards. And if it's social, then we have the step across beds down into the nurse-led for social circumstances. So I'm not sure if you can see very well, but out of the 59 patients that were admitted since March, when did we start? End of March, April time. Yes, April, May, apologies. Most of them come from our GP. We've had a few from WAST, and we're doing some work with WAST at the moment to see if we can improve our referrals as well. And then we've even had them come from clinics in GUH, from a nephrology clinic, and our heart failure team have admitted 12 beds as well. So it's quite a vast usage. On average, we're looking at probably 11 admissions a month. We're coming into winter, that could go up and down. It is the needs of the service. So, and I would say the discharge team are very good at creating beds to make sure that if the beds are required, we move patients on to admitting. The next slide for me is probably the most important, the one I like the most. Sorry, can you just go back? Just apologies, I meant the next graph. 47 of our patients go home where they should be. So for me, out of everything we do, if I can get 90% of them home, that's what we should be doing. We've got a few that go to a medical ward to continue medical intervention. The nurse there to the 4, apologies, I'm going up. They're mostly social continuing needs that need to be long-term care or looking into. We have had some that go to our GUH or to our LGHs, but obviously we always let them know that there's beds available in the ambulance. Next slide, please. So it all does another bit of good feedback, makes the day go right, especially for the nurses to know they're doing a good job, and for the families. So the nurse-led model first, feedback from that was one of the patient's family just wanted to pay recognition to the outstanding care the mother received on Tulare. And then I'd like to give heartfelt thanks to the staff on Tulare who looked after my dear long friend in her last days. And I put that one up because I think it shows that we don't just do on a nurse-led model patients that are awaiting discharge. We do all things. We do patients that are coming towards an end of a treatment for IVs. We do patients in their last days of life. So it just shows that, you know, as long as they've got the skills and we're our capabilities, we can manage all things within the nurse-led ward. Obviously, we do need support from other people. I enjoyed my time on the nurse-led ward. They listened to me and my concerns and helped discharge. It's one of the NPs looked after his patients. Nice to know that they thought we listened, because that's predominantly my job. I want to know that they feel listened to. The next one was somebody who talked to the chief exec a few years ago. I felt compelled to write to you regarding congratulating the nurse-led board. They helped her understand her needs. I'm going blind, honestly, in the glasses. Couldn't meet at home, and that she needed 24-hour care. This is something we've been attempted to address for a long period of time. So in doing this, they helped her with our family immensely. And for that, I'll be ever grateful. And that for me just spoke wonders. You know, not only did we help the patient, we helped the family. Yes, the patient went into 24-hour care, but that was the needs that the patient needed. And speaking to this family after, they all felt supported, and it wasn't rushed. It was a smooth process that they were all involved in. So the CRT beds, like I said, we're going 6 months now. It was one, for the bubble, it was the ambulatory bed. The service was on my doorstep for my regular infusion and quick to sort out. This patient's the blood transfusion. We go out, we do the bloods in the house, they arrange a time, they come in, have their bloods, 2 units and back home that day, with before they would have been accessing sort of St. Willis, Neville Hall, which is sort of about an hour drive from where she lives. And she does live in life, so she was always looking for taxis or ambulance services. And this patient still comes into us every 3 weeks. If I had to go into the acute, I wouldn't have gone. I'm glad the service was there. Our patients want the family around and be closer to home. So this for this little lady, she's been in and out of hospital quite a long time for the last few years. She's come in to us and within a couple of days was back home after the treatment she needed, and I'm glad that she had that. The next one is a family, it was from a family carer whose uncle was admitted to the local hospital, 12 beds, which prevented his learning disability triggers, which in turn helped my anxiety. It's an amazing service. I've had to explain to one team my uncle's illness and triggers, and felt the focus was in his care. That lady's actually doing patient story with comms team in January. The patient's accessed the bed 3 times due to complex needs, and accessed our hot clinic once. I think for her, she's met that team at home, seen them at hospital, and met them back out. And for the patient, it's but wonders, because he's had triggers that would concern, you know, he didn't like crowds, etc., that would have probably ended up on a longer stay. So that was something that was positive from both angles. Next slide, please. Yes, Caroline.
The next bit for us then is the vision and the next steps. So further develop an integrated hospital and community nurse practitioner. When I came to Yarb about 2 years ago, there's little pods in Blaenau Gwent of nurse practitioners, very small pods. You're talking 2, 3, 4 nurse practitioners per pod. None of them worked anywhere else, they worked there, and that was that. So we're in the middle of reconciling the differences within job descriptions, because there were many. And we're going with the All World, obviously, job description, and aligning those. And we're looking at all of them will be able to work, so they'll be able to cover all of the services within Blaenau Gwent. Just making sure that we've got a sustainable nurse-led ward and a sustainable community service. We're going to incorporate, when you're undertaking on, you've seen job planning, so that the nurse practitioners get some CPD time. I think there's a lot of work goes within the advanced nurse practice training, plus afterwards their portfolio is huge. They need to maintain their competence, their clinical skill set. That will change, so we need to you know, we need to invest in that and make sure that we are supporting them. Further training them for the assistant practitioners, so that's the unregistered workforce generally. There's a lot of skills that, you know, we could ask them to do and they want to do. So there should be a pathway for those for 2 to 3 to 4. So we've implemented some developmental assistant practitioners. We're looking at them taking on some of the reablement officer training. So we know if there's annual leave, bank holidays, weekends, the therapy service, that we don't have one. So they can carry on those therapy plans then within their remit as a healthcare support worker, which you would hope would decrease the stay, stop decondition of patients. So we've started that. We'd like to be able to support other hospitals to roll out a nurse-led ward as we have and to offer any support and guidance that we can. We're hoping that we can network with community teams to integrate further so that we could get direct admission from hospice to the valleys, for example. So again, so it just pushes the boundaries out a little bit more. As I said, doing some patient stories will start now in January, which I think is good. I think we need to communicate what we're doing. We need to get it out there and we need to sell the positive. And for these guys, part of their nurse practitioners, they've got to publish. So they need to sell the work that they've got. So that's within your, that's your, I don't have to do that, but Zoe has to do that. So within their pillars. So I think that's pretty much it from me.
Yeah.
And you've got to publish your results.
Absolutely.
How many times have I said that? Thank you. Thank you ever so much. You know I'm a big fan of the system because you won my chairman's prize.
We did.
Yeah, you have. It's really, really great. And the enthusiasm amongst both the patient and yourselves and your staff and the other clinicians with whom you met is really tangible. Up in Tulare, and it's a smashing model as we try desperately hard to maintain people in the community. And this is a really good example of what can be done with initiative and drive, as long as you publish your results. Are there any questions, comments? Rob?
Yeah, that's great. Really good news story. That's a question for you, but more for others. Are other CRTs across Gwent looking at what you're doing and implementing similar, or have implemented, or are going to implement?
So they've got direct admission beds on every site for each CRTs. That is being utilised, and I think obviously we need to start somewhere to see how it works and what the advantages, disadvantages are to it. And there's lots and lots of positives. So I think that it will be something that could look into the hospitals, but there is always a bed in each of the sites, so where Monmouth, all boroughs have got access to 1 or 2 beds, but this is just on a bigger scale.
Yeah.
And this is just where we're going with it. So hopefully.
I'll go last time.
Okay, Rob. So Phil.
We called Rob 3 times.
Sorry, Phil.
I'm just going to say, I think what this story shows is what you can do, what people can do when you get the right people with the right ethos in the right place, really. I mean, it's our services are delivered by people every day, aren't they? And what's made the difference here has been the people's attitudes, the way the nurses have approached it, the way the other professionals have approached it. That's what's made the difference. Yeah. I mean, it is a super unit, and a close relative of mine had some surgery in a 91st year in Neville Hall, transferred up to Yab with the idea that she was going there for a few weeks prior to going into a nursing home. The nurses in Yab were saying, actually, we think you can go home. We can do some work, you can go home. That was when she was 91. She had a 97th birthday 3 weeks ago. She has very minimal support. And if it hadn't been for those 2 to 3 weeks in Yab, it'd been nursing care and probably 6 months and gone. And I think that's the difference that you can make. But it comes from people, doesn't it? It doesn't come from all the bureaucracy and all the systems and all the other stuff that we spend all our time talking about. You do need all that, but actually it's about what the people can do. And that's what makes the difference.
Thank you. I feed that back. I know that there's a lot of drive for this to work, not just from myself as the leader of the run CRTT, but from all of them. If you come up and spoke, you're welcome to come up to speak to any of them. They're all very passionate on how, and even the doctors is very supportive, you know, that we can't do it alone. it's in conjunction with everybody that supports us and everyone believes in the service. And if you
Yeah.
believe in something, you want to make it work.
Yeah, and then if we look at some of the measurable stuff, for example, I think Blaen y Gwent, for example, has probably got one of the best kind of in terms of the tariff of delayed transfers. I think Blaen y Gwent is probably one of the best. So there is a measurable bit as well as all the added value that we add to people's lives.
Anna?
Yeah, thanks. Like others, I've been up to Yab and met Caroline, showed us around the facility and the wider Yab. And yeah, just to reiterate what we're saying, the sort of the leadership has been key here, hasn't it, by the local teams, and then being enabled to see opportunities and just taking it. We said a few times, didn't we, ask for forgiveness, not permission, and you're doing that.
I don't know how to do something.
But there was just something, so just thinking of like what can be done in this context. And we had a few conversations that I think there's about the opportunity for Yab in its broader sense, obviously the work in this ward, the CRT ward and Tulare ward, but how we can maximise what Yab has to offer, not just, but particularly in the context of conversations we're going to have about Neville Hall, but we were scoping some things out and had a few cunning plans as well that we need to factor into our planning there as well. So it's about Yab and what it can do, but also about how it can support what we'll need to do more broadly as we look at services in that part.
Thank you. Paul?
I just say fantastic work. And looking at it, the word closer comes up, which is closer to home. And I think patients, carers, the whole thing is like a very locally based model. But the one thing I want to say was I chair the Charitable Funds Committee. And I think if there are particular projects, we haven't got a huge amount of money, but if there are particular projects that you were thinking, actually, we'd quite like to look into that, then please feel free to contact the charitable funds.
I wish we never said that, but thank you so much.
I think that the point is that this is something we should be replicating, really going out, because I think some of the comments, the feedback has been incredible, and so the more we can do to help and support you in doing that. And as I said, it's not huge amounts of money, but there is funding available for you to have a look at, which may be either for engagement or for conversations to be had or whatever you need to look at. And I think it's Alison who sort of coordinates it all, would be able to give you some advice as to what might be available. But we've got a friends group as well at the hospital.
So League of Friends.
League of Friends.
Yeah.
And how does that?
They're really good. They're recent, so they've just helped us to set up. So we wanted to do the reablement officer training for our healthcare. And we needed some equipment for that, and they bought it all.
Yeah.
So they bought it all. So we'll put some stickers on and we'll do something for social media. But they're really good. They're really supportive on there.
And I think you'll probably find that's a payback in terms of you investing in the community. They're more than happy to fund and reinvest back into local work. So just to be applauded and say well done to you and all the team. Well done.
Yeah. Cool.
Thank you, Paul.
So, one of the things that's really important is that there is an opportunity for Yab, but there's also an opportunity for the health board in terms of understanding the impact of Zoe and Caroline and the broader team's work. And it's one of the work streams that we've got in place as part of the redesigning services for older and frail people is around what is our community hospital model of the future, because it's more than likely something different to what we have now. And actually, we know the model that Tulare Ward works. We know that the CRT opportunity around direct access gives us a different opportunity to avoid admissions. And we know that frail older people don't do very well in our acute system. So I think it's really important that through the 6 Goals programme, we pick up the learning and consider the opportunities to spread this, because I'm not about, you're here in the nursing strategy. I've got huge ambitions for nursing in Aneurin Bevan, and I think this is a fantastic opportunity to demedicalise care, provide care closer to home, to avoid our acute system, and to ensure that people get care in the right environment by highly qualified, highly trained individuals, such as Zoe and Caroline and others.
Thank you. And thank you very much.
Thank you very much
for coming and keep up the good work.
Thank you. Thank you all. Thank you.
Thank you. 3.1, the Health and Safety Annual Report, please.
Thank you, Chair.
Peter.
Thank you, Chair. I'm joined by my colleague Scott Taylor, who's on Teams. Scott is our head of safety, but I shall present this item. The purpose of this item is to present the board with the Health, Safety and Fire annual report for the period 22-23. With the annual report, there is an accompanying report which explains the functions of our corporate health and safety department and sets out the various pieces of health and safety legislation. And I've deliberately included the specific wording of the legislation because that's quite important to help us understand what it is we're required to do as a health board. The report also explains the current governance and assurance arrangements for the health board around health and safety. Important to note that health, safety and security is one of the pillars of our health board quality strategy, and I was really pleased that we were able to include that within the quality strategy. The report accompanying the annual report identifies both opportunities but also challenges for the health board in ensuring and sustaining compliance with health and safety legislation. So from the 22-23 annual report, we have identified 7 risk areas for focus, and whilst I'm not going to go through the entire annual report, I want to focus on those 7 risk areas, which I kind of cover off in turn. So the first one is around manual handling training. In terms of the 22-23 report, the manual handling training compliance was 52%, which is below our target as an organisation of 85%. Whilst we have seen some improvement since then, and the current performance is up to 55%, there is still a lot of improvement to be made. The work that we're doing is to look at our staff groups and understand them on a risk-based approach and approach statutory mandatory training through the lens of risk. We're also looking at manual handling training in terms of who needs practical training and who can benefit just from online training. So we are looking to now make some changes in the way we approach manual handling training, which we feel will give us some significant improvements in terms of our compliance as well. Another area that we've identified as a risk area is RIDDOR reporting. So RIDDOR is the reporting of injuries, disease and dangerous occurrences regulations. And that's a particular piece of legislation that as an organisation we need to comply with. Important for me to say that in terms of RIDDOR reporting, we do, I am satisfied and I can give assurance to the board that we do report all RIDDOR reportable incidents to the Health and Safety Executive. But the element that we're challenged on is the timeliness of that reporting, and there are specific targets given to us by the Health and Safety Executive for timeliness of RIDDOR reporting. And so in terms of that area, whilst the annual report indicates that we are only reporting 49% of incidents, 49% of were reported outside the legal timeframes. It has improved somewhat. We're now at 65%. If you look at the annual report, you can see month by month the performance, and it is very variable. And even to the point that at March 23, we reported 100% within our legal timeframes. So it does vary a lot, but that tells me that it is achievable. We've identified in the paper a range of activities that we're undertaking to improve the timeliness of RIDDOR reporting, because we place a great deal of importance on this. We've developed a RIDDOR dashboard in our DATEX system, which allows us to have more detailed and active and live monitoring of RIDDOR reports. And that's really supporting the health and safety team in terms of that monitoring and being able to take timely action. We've also improved communication with our Putting Things Right team, and in terms of when the incidents are reported, but also understanding the requirements around RIDDOR reporting, particularly around inpatient falls. And we're also looking to introduce a standard operating procedure for managers when they complete incident reports on DATEX, which will provide effectively a flag to prompt risk reporting and encourage more timely reporting. So there's a whole range of actions that we are taking to improve our compliance of reporting there. The next two areas, health and safety monitoring and health and safety risk assessments, were two areas of risk for us that were identified as well in internal audits. And we had an internal audit in 17-18 and then a follow-up audit in 19-20. And these two areas remain recommendations for our internal audit in those areas. So really important that we now see some improvement in these areas. So in terms of health and safety monitoring, that relates to our audit and inspection programme that we undertake as a corporate health and safety team. Through the last year, 22-23, we really focused our monitoring on respiratory protective equipment. That was because we considered that to be a key area of priority for us. To enable a health board to measure compliance against health and safety legislation, a programme of audits and inspections will now be determined by the corporate health and safety team and taken to the health and safety committee for agreement. I'm confident then that that audit programme will allow us to increase our level of monitoring for health and safety to importantly gather that intelligence that allows us then to take action. In terms of health and safety risk assessments, this is really about the quality of risk assessments that are undertaken throughout the organisation. And again, the internal audit provided only limited assurance in terms of the health board's quality and standard of risk assessments. So in order to provide assurance that suitable and sufficient health and safety risk assessments are completed at a divisional level, we will be carrying out we'll be asking the divisions to undertake a self-assessment. We really want to understand at a divisional level about the risk assessments and the quality of them. And that will allow us to gather more detailed intelligence around the quality, but allow us to take more targeted and specific actions, working with the directorates and divisions to improve and raise the quality of their risk assessment. The next area of risk for us that we're focusing on is our fire safety risk assessment. So these are the risk assessments that we undertake throughout the organisation, and we're a large, complex organisation with many facilities, as you know. It's important to say that in terms of the fire risk assessments, all areas of the health board that operate do have fire risk assessments. But as an organisation, we've set our own standard that we want to review those fire risk assessments on an annual basis. That's our own health board standard that we've set. That's not the legal requirement. That's our own standard, and I think that's an important one, and one that we feel is important to maintain. And it's that element that at the moment we're going to be achieving that on an annual basis. So for the annual report period 22-23, we conducted 66% of our fire assessments were reviewed within the year. So there's still a gap in terms of our ability to get round and assess them. That's something that we aspire to do. Whilst the health board, the main contributing factor to the deficit of the review of fire risk assessments is largely supported, is related to the capacity within the health and safety team. So what we're looking at options to address the backlog and ensure that the number of overdue fire risk assessments do not increase further, but also we can bridge the gap. This includes reviewing the frequency of the low hazard fire risk assessments. So what we're looking at is the different facilities across the health board, understanding the difference between those that are higher risks, so the patient facing areas, and those that are non-patient facing areas, and taking a risk-based approach to the fire risk assessment. So really changing our approach, much more intelligent approach, so we can look at fire risk assessments, not just as a blanket approach of everyone being reviewed on an annual basis. Probably important to say that we have a really close and positive relationship with the South Wales Fire and Rescue Service. They are active partners with us, and they support us with inspections and advice, and that is a really positive relationship. And some of the work we're doing here around fire risk assessment, we can only do in conjunction with them and with their advice. And that brings me on to the next area of risk, which is fire alarm systems. So obviously with a state across the health board, which is large, complex, but there are areas that are very old. There are some of our fire alarm systems which are old and end of life and need replacing. just to give assurance to the board that all of our fire alarm systems are in working order and do work, but we've identified some of them which are old, end of life and need replacement. And we have a process for that, and we're working with colleagues within Capital to identify capital resources to replace our fire alarm system. We had specific funding from Welsh Government around that, what we often refer to as the EFAP funding, to address those areas. And where we're up to with that is we've got funding now to address, to rectify the problems at the Wall Gwent, and that work is underway now, and we've got plans around that. The South Wales Fire and Rescue Service are content with our plans around addressing the fire alarm systems. The next area is fire compartmentation. And this just to try and explain it in a very simple fashion, these are the physical fire barriers that stop the spread of fire in our buildings. And it's important that the fire compartmentation system is up to standard with current spec and standards. Obviously, again, related to some of our older estates, this can be quite challenging. A lot of this is about you don't know until you do a survey that you have a fire compartmentation system. So we're working through a process with our South Wales Fire and Rescue Service in supporting that survey work. On the back of that, we've identified some improvement schemes. So one is the repair of fire partitions at Neville Hall, and then also at St Willis. And we're also beginning to start a survey at the Wall Gwent Hospital. All of this requires capital investment, so it is dependent on us getting the supply of capital funding to make this happen. Again, I should say that in terms of the fire compartmentation system, we're satisfied that the areas that we operate in the Health Board are safe, and that we have appropriate mitigation in place to keep those areas safe while we do that work. And that involves making sure our fire alarm systems are working, and that we have clear evacuation plans and staff training in place to keep our staff and public safe whilst operating in those areas. So there are 7 risk areas of focus. I'm really keen as the executive lead for health and safety to address those 7 areas at pace. I'm working with Scott to develop a rapid improvement plan, which I hope to have complete by the end of March. So complete as in terms of the actions completed. And then beyond March to put in place a 3-year health and safety strategy, which will effectively form an ongoing programme to make sure we sustain compliance with health and safety legislation. So it is a really challenging area. I recognise that the capacity within the health and safety team is limited. There isn't an opportunity for investment, I understand that, but it is about thinking through the way we work as a corporate health and safety team in the organisation and adapting our approach. What I think that translates as is us working in a different way with divisions and directorates in a more collaborative way, and creating more ownership at an operational level around some of the health and safety requirements, which will allow Scott and his team to take a much more expert advisory and monitoring role. Some of the work that we want to do immediately, that is an immediate action for me, is to undertake a quantified risk assessment of those 7 areas so we can update our risk register, and that can then in turn inform the Health Board's corporate risk register. We'll also be reviewing the terms of reference for our corporate health and safety committee. We have a health and safety committee which I chair, but I'm really keen that we now review the terms of reference and membership of that in particular, and consider how we can strengthen it in terms of additional executive membership. So I'm really keen that we do that, certainly before the end of March. So the board, I'm asking the board to consider the annual report and approve the annual report for publication, and to note the risk areas that I've identified, the 7 risk areas, but the work that's been undertaken to address those risks. The Health and Safety Committee will provide further assurance on this work to the board in due course.
Thank you, Peter. Questions, Pippa?
Thank you. I've got 2 questions, and I know that some of this obviously gets reported through Patient Quality and Safety Committee. And I think the 2 questions, the first one's around the manual handling training, which obviously we're aware is it's not quite where it should be, and it's an improving picture. But it's a question of the sustainability of it, and there's obviously going to be a big push to get it up to the right numbers now, but about tackling that sustainability. So that's kind of my first question, and how's that going to be monitored moving forward, and would that be through PQSO? So that's the first question. I don't know if you want to answer that one first, and then I'll move on to it.
So we include health and safety within our quality report now. So that obviously the report that goes to PQSO, but also comes to the board, and you'll see in the quality report that we're going to look at later in the agenda, there's, you know, health and safety is featured in there. The data around manual handling, we have that's through our ESR system, and we can easily capture that. In terms of statutory mandatory training, we've made really good improvements in the health board in terms of our compliance with that, but manual handling remains the challenging area, and that's because unlike the other statutory mandatory training that can be done online, the manual handling requires a practical element, and that is the rate limiting factor really to achieve compliance there. What we're doing is working with Sarah's team and Workforce and OD to identify alternative ways to deliver manual handling training on a risk-based approach for different staff groups. Some of which will not need face-to-face classroom training, but can be done entirely online. That will be a game changer for us in terms of improving manual handling training as well. The other work that Scott and his team are doing is to equip divisions and directorates in terms of cascade trainers. So it's not necessarily Scott and his team that have to do that training, but almost kind of putting the trainers out there in the organisation. So we've got a much wider and bigger resource to deliver the training as well.
Thank you, and I'm guessing that's going to come through that committee as it goes along. My second question is one that you may or may not be able to answer, and it's around the fire alarm system and whether or not the situation with Neville Hall at the moment is just whether that alters that or not.
In terms of the
RAC,
yes. Scott and his team are working really closely with our facilities team as well in terms of the health and safety risk assessment related to RAC and how it impacts on fire. We're satisfied at the moment that the areas affected by RAC are safe in terms of being able to use them. Obviously, some areas have been taken out of action, but the areas that are in operation, we can think they're safe, and Scott's team are able to provide that assurance in terms of safety. Where we get challenged sometimes on both fire alarm systems or compartmentation is when changes are made to the environment. So if we do building work or something like that, that can disrupt the normal layout of the building, or even it can damage the fire compartmentation. Scott's team work really closely with facilities to make sure that when Works for Estates colleagues are going in doing work and it's sometimes as well with IT as well, we put new IT systems in, that we follow behind and make sure the compartmentation or the other fire safety mechanisms are all put back in place as well. But in terms of fire alarm system, it's an ongoing programme of upgrade. You can imagine that you buy a fire alarm system, it only lasts so long, and then it becomes becomes end of life, and you have to replace it. And so that's kind of the life we've been in for the health board, as long as I've been looking after health and safety, that with this ongoing replacement of fire systems. At the moment, we're working on the ones that the Royal Gwent and St Willis as our priority areas.
Hang on, can I just ask? The content of this report is very concerning indeed, and we expect as a board rapid action to be taken to rectify the deficiencies that you've identified. What I don't understand, I don't personally think it is the sole responsibility of the specialist teams to rectify all this. What exactly is the responsibility of the managers in charge of the department? And have they been trained to understand fire, particularly fire safety and the importance of manual handling and our responsibilities as an organisation?
Yeah, I agree with that point, and I think the answer to this is about equipping our managers throughout the organisation, all of our staff actually, in terms of we've all got responsibilities in terms of health and safety, and we do have standard health and safety training. I think what the report tells us that in itself is not enough, and we have to go further than that. In terms of our ability to make the change and achieve the improvement. I think what's clear to me is that we can only do that with the divisions and directorates. The corporate health and safety team can't do it on its own, and I think that's the mistake we've made before. We tried to do it that way, and we've got to engage the divisions and directorates. That will mean additional responsibility and additional expectation on divisions and directorates, but that's our intention through the corporate health and safety strategy that I referred to really change the emphasis in terms of where the responsibility sits. And I'd say that the corporate health and safety team need to take on much more of a role around expert advisors and monitorers and auditors of the system, and equip the divisions and to be able to actually do the doing what we really like in terms of that. So I think it's probably the most important element of the change we need to make. The responsibilities at division level.
And it needs to be done rapidly.
Yes.
Because we can't.
No.
Can't continue like this. Shelley?
The question was around the riddle, and I just wondered if there's a penalty for not reporting within the timescales. And the other one was the risk element of, because I noticed in here this obviously isn't on the risk, corporate risk register. I appreciate you will have an operational risk, and you'll say you're going to review that. And I would go with that. I think that needs to be reviewed very quickly, because you know, that's the point. At the moment, this isn't necessarily on our radar as an overall area. So I'm not suggesting, I mean, it may not come up, it might not meet the criteria for being on the corporate risk register, but I think that assessment, you know, should be done sooner rather than later. I appreciate it.
Yeah, and I just do deal with that one first. Absolutely, Shelley. That's our intentions, to update our health and safety risk register to quantify that so that it can then inform the corporate risk register. Absolutely true that we need to make sure that at a corporate level, we understand the risks that sit in health and safety, and whether that then needs to feature on our health risk register as well. That's an immediate action that we're taking in order to quantify that. In terms of RIDDOR, we report RIDDOR to the health and safety executive, and they will make decisions about enforcement action if necessary, and that does come with a fine. At the moment, they haven't fined us in terms of compliance of RIDDOR reporting, but they, you know, we work closely with them. So yeah, I mean, RIDDOR reporting is really important. I feel quite confident about the mechanisms that we have identified to improve the timeliness of RIDDOR reporting. Whilst I'm content we are RIDDOR reporting, I'm not happy with the timeliness of it. And that's definitely an area that I think we can improve on. And again, that comes back to divisions and directorates. The onus needs to be on them and the responsibility. So when an incident is reported, it's not just about the incident taking the action and closing it down. It is also identifying the RIDDOR requirements attached to that incident and then taking action in a timely way. We can work with the divisions and directorates now, and using some of our digital resources with Playtex, we can really kind of put the almost kind of fail-safe mechanisms in place now to make sure we catch those RIDDOR reports and do them in a timely manner and not allow them to drift. It's clear that there's been some challenges around that, about timely reporting of incidents makes a difference to RIDDOR reporting, so we must report our incidents on time in the first place so that we can do the RIDDOR reports, but also we must complete investigations and close them down on time as well. So there's some work to do there in relation to incident reporting that will naturally improve RIDDOR reporting.
Nicholas?
Yes, so it was just to reinforce. So the 22-23 health and safety report has triggered a response by the executive team on this. We've had a few sessions of the executive team, and we're really, you know, we want to make sure we really pulled out those risk areas into the board report. We particularly concentrate, you know, manual handling and fire in particular, you know, sharing the concerns. He's been through the executive team with Peter on a number of occasions, and it's really, you know, what are we going to do about this? This is, you know, it's not to be, and we need some rapid, hence the improvement work that Peter's referred to. And I think we've had the discussion, Shelley, around the risk register, you know, reviewing the strategic risk report. Health and safety really is an on-year feature in the way that we think it needs to be. And hence that work Peter's doing now to quantify that risk so we can pull it into the corporate risk register for the next report, hopefully. And really trying to, you know, look at with Scott and Peter and what can we do with the resource we got? Can we do things differently, prioritise work, look at what the divisions can do, and what else do we need to do to
speed on this, and also trying to understand the legal regulations versus our own standards we put in there, trying to understand how, how we compare on those two, because, legal responsibilities is absolutely fundamental that we need those. So yes, I just wanted to reinforce that the report for 22-23 has triggered an escalation of this issue for us as an executive team. Response as well then.
Yeah, well, it's adding on to your point, I guess, Sam. I mean, obviously, this is an area of concern. Should be an area of concern for us all, because I think we're all personally on the hook for this kind of stuff. And this has obviously been an issue for quite a while now. There have been audit points outstanding since 1718, I think it is, and the last annual report was 16, something like that. Do we need to bring somebody independent in to support the exec in actually doing a full review of this and seeing what the issues are and getting to the bottom of it and actually getting that list together of this is what we should be doing. These are all the bits that we have done or haven't done. I mean, this risk report is 8 months out of date, in effect. I don't know where we are this year in terms of doing our fire risk assessments, etc., etc. So do we need to bring somebody independent in to give us that assurance that there isn't a ticking time bomb out there? Because this does worry me. Something goes up in smoke around here, we are liable. Everybody around this table is personally liable.
Peter?
Yeah, I mean, that is absolutely right. And in terms of the report, I tried to reflect not just what the annual report for 2022-23 says, but where we are currently, and just demonstrate there has been, while small, some improvement. Not to the level that we need, but there has been some level of improvement. But I feel that through the work we need to do to strengthen our corporate health and safety committee, particularly in terms of the membership of that, and the rapid improvement plan, and then beyond that, the strategy. I think we need to do that work and understand where we sit with that, and that will determine whether we need to bring in some additional help. I believe. I'm confident with the team we've got and the support that I've got from my executive colleagues that we have got a renewed and stronger focus on this, which gives me confidence that we can deal with the risk areas that we've identified.
I think we'll have to have a report back on that in January.
Yeah.
Because, there is obvious concern amongst the whole of this board.
I think we take, I think it's a helpful suggestion when we pick that up and take it outside and consider what those options could look like and how we could, because I agree with you, we have got to escalate this, and I am worried about to share your worry about it, and I think, maybe that is an option we can look at, but I think we take the assessment about the speed. I think it is about speed on which we can do that. If not, how can we get some of that?
Very rarely you'll hear me talk anything about finance, but
I agree.
Get on top of this, and the fact that today how far we are behind on fire risk assessments is, this is critical stuff.
And I think that point that was made is how do we make this more front and centre of some of our reporting? Every month, because some things are it comes up more through the annual mechanism rather than, which is, as Peter said, we've now embedded a lot of that in the quality report, but we need to check. I think you're right. We've got to get this from you.
And it's as simple as that checklist.
Yeah.
How many fire risk assessments do we have to do during the year? Where are we? Why are we behind? Is it the electrical safety test, gas safety testing? We've got a lot of dangerous stuff knocking around in this place, from what I've seen. I think we've got to be, it's the basics and everything else in the water tank. When do we last clean a water tank? No idea.
Yeah. I agree. I'm clear that all of our areas have got fire risk assessments. It's about our own standard that we agree to review those on an annual basis. And I think that's the right standard. Actually, it's that we've not achieved. We've not been able to review them on an annual basis. But all of our areas do have fire risk assessments. And we do work really closely with the South Wales Fire and Rescue Service in terms of they have a rolling programme of inspections, they work with us, and they're very supportive. They sit on our fire committee that reports to the Health and Safety Committee, work really closely with us in terms of supportive and advisory capacity. But we do have fire risk assessments for all of our areas.
And
I think so.
that doesn't come out in
No,
this
it doesn't.
report to me at all. And our standards still trump anything legally. If somebody comes in here, or internal auditors come in, they will measure against our standards. We need to change us, that's a different thing. But none of that is coming out in this report as to where we are. So I gain very little assurance from this report that we.
Thank you, Ian. Paul?
I mean, part of our role is to hold into account, and also we have a duty of care over our staff. When I read this report, like you, Anne, I was horrified by what I read in some particular areas. There's 7 areas that have got to be particularly looked at. And then obviously there's a lack of resource to support the legal requirements of health and safety and fire was also mentioned. You've talked about this needs to be escalated, I think, rapidly. I think an interim position statement in January is what we should request on that. I think we should consider independent advice being brought in to look at this area. We are incredibly at risk for some of these particular areas. And I think that we need to also support our health and safety team by helping and supporting them through that. The manual handling training has been covered, but that, in again, there's a huge risk there with regards to possible issues for us unless that's addressed. But I think Peter's explained that. But I also looked at the violence and aggression. There's an issue about accuracy of reporting, and according to my calculations, there's 2,300 issues a year with regards to threats, physical and verbal, and that's 6 a day. And again, what is being done to support staff with regards to that particular area of activity, which can cause a lot of stress, anxiety, and staff being off. And of that figure, over 50% have got mental health and learning disability. And again, what is being done to look at that? So I think actually what I haven't seen really is the detailed improvement plan, which incorporates all these sorts of issues. And I think an interim position statement in January outlining all the issues with all the actions that are proposed. I mean, it mentioned that an improvement plan will be developed for 23-24. But we're 8 months into that. So I think this is an area of risk for us. And I think, this is an opportunity for us to say to the team, what can we do to help and support you to address these issues? Because that's what we're here to do. But I think this report, and I think it is important to say, that I think it is incredibly important that we do have these open and I think the information's open and transparent, which I think is incredibly important for us to say, okay, what can we do now to help and support you to get things right very, very quickly?
Thank you, Paul. I think we'd all endorse that point of view. Bill?
Yeah, nice to say, Chair. I think there is a level of risk. But what I get from the report is that risk is being managed. I think it's a managed risk, which I think is important to state. And in terms of the fire issue as well, I think what we're hearing is that we are compliant with the law, possibly, but we're not compliant with our own standard. And we want to be compliant with our own standard, but our own standard is better than the law. So our own standard is better than the limit, I guess, they don't have the medium. So I think we can take some kind of strength from that, I think. We're not saying that we're falling below the law. So, I mean, if the fire service were to walk in and they do an audit, they wouldn't say, for example, that we're breaking the law with what we do. So I think that's positive. In terms of the manual handling, I wasn't sure from the report whether it's a capacity issue in terms of training, or whether, I guess, what we're seeing is a result of the system being stretched, really. Because if you take this discussion out of this room into an operation environment, then it's easy to see why health and safety can sometimes be pushed to the end of the line of things that you have to do. We talked about managers, and I think what we need is perhaps a soft stick for some of our managers now to try and understand the pressures they may be under with this. Because if you're trying to staff services, then and I've done this myself as a manager, I've often said to staff, they've said, I won't be in Thursday, I'm doing manual handling training. And I've had to say, actually, you can't do that because you've got to be on the job. And I think that's the reality of some of this as well that we need to try and understand. It's much more difficult out there than it may be in here. And I guess the sustainability of manual handling training is more of a problem. The only thing I was going to say on this, actually, but I've said more, is there an answer with our partners in terms of manual handling training moving on? Because, of course, all councils have big manual handling training issues. And I just wondered whether we could almost set up, in terms of sustaining the service, almost a Gwent manual handling training school or something, which I know some parts of the country have done. So you share resource, you share the difficulty of staff. I mean, it could even be a non-profit making kind of standalone organisation, really, going forward, because there will be plenty of business there. So I wonder whether there could be a partnership discussion around that. Because, of course, one of the difficulties of manual handling training is the less of it that you do because of work pressure, ultimately will increase work pressure because more people will be injured and more people will be sick. So it's almost, isn't it? But it is not an easy one to get right.
No. Thank you.
Yeah, just briefly, I think for me, I do gain some comfort from the fact that you have at least identified what the risks are. I would be more concerned if you were saying, well, actually, we think everything is fine, but we don't know. And I think the fact that you have actually identified key areas that you're focusing on, I think is really important. And then it's just about us monitoring to the sustainability point, I think, which is the thing that probably concerns me the most. So it's a question of how do we assess and evaluate quickly and then monitor moving forward. I think it's how we do that, I think, is really important.
Shelley?
I accept what's been said about the risk and feel that, you know, that there is assurance, you know where you are. I think, like, for me, it's, but what's our risk appetite on this?
Yeah.
That goes back to Ewan's point. I think we're low on this. So if you factor that in, then I don't have the assurance that perhaps at the moment that we do need, which as we discussed.
You've heard the views of the board, which I think are pretty unanimous. So we'll have a report in January on progress and what remain the hurdles for you and how you're getting on with directorate and division responsibility sharing and action. Thank you. Thank you, Scott. Nursing and midwifery strategy.
So in the interest of time, Linda joined us in uniform to talk this through. And as you'll know, Linda and I have been really keen to raise the profile of nursing and midwifery in the health board. We've worked a strategy with Sarah, which really sets out our ambitions to develop the nursing workforce in the future. And this very much develops the professional nursing approach and where we want to be in terms of our ambitions for nursing and midwifery within the health board. So over to Linda.
Thank you, Jenny. Thank you, Chair. So very pleased to share with board our nursing midwifery strategy for 23-26. And as Jenny quite rightly says, it sets out our ambition and vision to support the continued growth and development and innovation of nursing and midwifery practice within Aneurin Bevan. We don't wish for it to be considered in isolation, and it really needs to reflect the priorities which are articulated in our IMTP, our people plan, and as you are aware, we've already previously shared with board our nursing and midwifery workforce strategy. So the strategy is framed by a series of 5 strategic ambitions and for the next 3 years. And this was decided collaboratively with our nurses and midwives. So it was done through a series of workshops in order to pool the priorities and ambition together. There's 5 strategic aims within this strategy, and you will see there are some similarities. There's too many R's. Similarities to our nursing and workforce strategy. However, there's 3 specific aims which we really want to focus on within our new strategy, which is quality improvement, innovation, research and professional identity and influence, and really strengthening the nursing voice within Aneurin Bevan. And just for assurance with regards to overall progress and delivery of the strategy, this will be delivered by Jenny in a role as Exec Director of Nursing. It's really intended to encourage pride and enthusiasm in our profession and within ABHB, with an overall vision of ensuring a positive impact on outcomes and experiences of our patients. I'm mindful that the strategy is fairly long. I think there's around 24 slides. I wasn't planning on going through each and every one, but obviously happy to take any questions that board might have in regards the strategy and its delivery.
Thank you, Linda. Do you wish to add anything?
Just to say, really, I gave evidence to the Health and Social Care Select Committee of the Senate recently, and one of the things I said was that I was incredibly proud of the nurses that I see every day in Wales, and in particular in our health. I think the talent, the enthusiasm, the commitment to nursing and to the nursing profession is huge from our nursing colleagues in this board, and just the way in which they are the guardians of care day in, day out, every day, no matter how busy it is or where they work. And I said to the Senate, I am so proud. I don't want to work in England again. I want to have the rest of my career in Wales, and it's because of, I think, sorry, I'm losing my words, just the way in which the nursing workforce in this health board gives every single day and does it with pride and with a level of humility I've not seen in many other places. And I think we wanted to recognise that, but be ambitious and say, this is our stamp for the future. Sorry, I got a bit.
No, that was really so. That was really,
Lost my
really
words.
good. No, thank you. Helen.
Thank you. I just wanted to comment and just say thank you to Jenny and Linda. Obviously, it is a very detailed and very ambitious strategy. It's very moving to see that you actually, your comments from the reaction of the staff and their actual engagement to it. On a separate note, I was obviously very pleased that you'd included research and innovation in that and encouraging nurses to get involved with those aspects, because I think that also gives them more incentives and encourages them to do things and see how they can improve the care around it. Obviously, lots of detail in that strategy at the moment, and obviously I'm sure you are working on, and it says at the end obviously about your action plan to follow that up. That's obviously going to be the key to get this into across the board and to actually get progress on it. But well done for getting this far, and look forward to seeing the sort of action plan and timeline that goes with it, so that we can see what progress you're making, and the nursing, your community of nurses can see that as well and see how they can get involved and what progress they can make in their career progression as well. So well done and good luck with the next stages.
Thank you. Thank you. Are there any further questions?
Well done.
Well, I think this has gone down very well. We've all enjoyed it.
I do apologise.
No, it's very, very important. We constantly hear about concerns about not having sufficient staff, not having staff in the right place, and to have a health board that actively encourages and develops its workforce is critical to success for the future. So I do hope you publicise this extensively.
We will do.
And that the rest of Wales takes a bit of a step forward as a consequence. But this is really important at a very critical time for our staff, when they can be feeling undervalued and not cherished. And this shows that actually we value them exceptionally highly.
We do.
Good. So we'll have a nice report on the action plan and timeline next time, please. Is that all right?
Thank you.
Thank you ever so much for your hard work on this. Really good. Thank you.
Thank you. Bye.
Thank you. Bye bye. Quality and Safety Systems Framework for Speaking Up.
Thank you, Chair. The Speaking Up framework, which is contained as an appendix to the report, has been in development for some time on an all Wales basis. and it was released on the 25th of August, probably a little ahead of planned time due to the consequences of the Lucy Letby case, which has been well publicised. And as a consequence of the publication, all NHS Wales organisations were asked to undertake a self-assessment against Section 6 of the framework. So colleagues from Jenny's team and my team have worked together from a quality and patient safety, safeguarding and employee experience perspective to undertake a high-level assessment against the Section 6 standards of the framework. And you'll find in 3.3D the detail of that assessment with some correlating actions that need to be taken forward. There are a range of actions to be completed, but they very much take the approach of integrating the framework with our quality and safety strategy and employee experience programmes, very much using an evidence-based research and learning approach. And ahead of the release of the strategy, we had planned a workshop which took place on the 3rd of October. Some colleagues attended that workshop. And was multidisciplinary approach supported by Professor Ali Jones from Plymouth University, who is a specialist in the field, and recognising that policy application or framework application by itself does not deliver a change in behaviour and values. And that's very much what we want to focus on, but bearing in mind that real change will take a longer term time frame than the initial actions outlined in the assessment. The assessment acknowledges that there's a great deal of work to do, but it's worth noting that we're no different from any NHS organisation, and colleagues may be familiar with some of the evidence and research that's available across the UK in terms of difficulties with encouraging people to speak up and do so in a protected way. But the report, which is available for the board, also notes the actions that the Health Board are already taken in terms of implementing and supporting the Speaking Up Safely agenda. Most recently, we've launched an independent raising concerns email address, which has been active for the last couple of months. We've already received 21 concerns, 6 of which have been investigated and looked at in more detail, and we'll be in the learning on those themes in future months. The costs potentially of the action plan are also noted in the report, but they're quite high level at this moment in time and be worked through in more detail. And you will note from the primary action on the assessment that we need to identify an independent member of the board as a champion for speaking up safely, and discuss that with the chair, and also Louise Wright, who is willing to undertake that role, and also that's a good link in terms of the trade union representation and partnership working on this agenda. So that's a summary of where we are today. So before I bring Jenny in to see if you want to add, I'll just say that the board is asked to note our assessment, provide any views and comments, and also endorse Louise as the independent champion. Thank you. Yes, Jenny?
Just to add to what Sarah said, as you know, I'm very passionate about experience, and that is a key plank of quality. And for me, this is really, really important development. It was something that was introduced in England a few years ago. It's been really pivotal in terms of ensuring that staff feel psychologically safe to raise concerns. It's been important in terms of understanding, when you look at the data and you look at the information, what that means in reality for our staff and what that can mean for patients. And it's a key plank for me in terms of our total assurance around quality. So I would very much endorse this one.
Thanks, Jenny. Ewan?
Just to add to it, it's been brought up in audit committee as well. So we are looking at potential internal audit around the whistleblowing and how issues are escalated up to the board as well.
That's helpful. Thank you. Any further comments? No? So we endorse the speaking up safely. Thank you. Thank you. Thank you very much. And we endorse Louise as the champion. Yeah. Well done, Louise.
Thank you.
Thank you. Thank you. She did. 3.4, the winter plan.
Thank you, Chair. So the purpose of bringing this to today's approval for the winter plan. The plan has been developed in partnership with local authority colleagues for partnership elements and with operational colleagues through a series of workshops. It has been through exec committee recently where it's this version was updated following sort of the challenge there. In terms of the partnership piece, which is sort of subset of this, that committed slippage from the RIF funding, which I'll come on to in more detail later, and that was approved to deploy that RIF slippage in line with the proposal that was approved through the last RPB meeting. So what's the plan about then? It is really intended to provide and give us some resilience in our services to meet the anticipated pressures of the winter. As I said already, it is really important that we do that with our partners, our local authority partners, and really key to the approach this year has been that the evaluation and the learning from things that worked and more importantly things that didn't work last year that we previously have received at board, that we factor that into the planning for next year, for this winter, and also that we build on some of the activities and maybe strengthen some activities that we're already taking through some of our system work in terms of response and improvements to the urgent and emergency care system. So specifically the six goals programme. In terms of then the sort of assumptions upon which we're planning, you'll see from the report and the plan, we are expecting, based on the intelligence we've received, up to a third of our beds will be occupied with patients with respiratory disease, and that peak will be in January. We're also expecting we could have an up to a 10% absence rate for staff due to sickness and illness. And we are assuming that the pressures persist, that there's nothing going to happen that will unfortunately alleviate the pressures as we go into winter. So I'll come and talk you through the key principles and themes of the plan. And I'll come back to some of the risks and context, but just to note, this is in the context of the financial position we're in, which is an important parameter for the plan. And it's also, and as I said, I'll come back to it, in the context of some impending risks, particularly around industrial action, which will, if they transpire, hit us in winter. So you'll see from the plan that there are 4 principles and themes that frame the plan, one around partnership and prevention, and then from a sort of a very operational perspective, capacity, processing power and focus. I'll just pick out a few parts of the plan. So from the partnership prevention space, clearly the vaccination programme, both COVID booster and flu vaccination, is a real bedrock of our plan. Our target, our ambition around the COVID booster is 75%. We're at 45% at the moment, so clearly a lot of work to do there to improve that position and bolster our resilience going into the winter. And similarly, the flu campaign, both internally with staff and with schools, care homes and social care staff, is a real important plank of this agenda. You'll see from the detailed plan that there are a number of initiatives that we are taking forward via RIF funding that are really in that partnership space around preventing and avoiding admission, through to some of the WAST Falls response service that we've commissioned, but we'll be commissioning via the additional money, the mental health practitioner response vehicle, care and repair support. So there's a range of initiatives, again, with evidence behind them that they will support us and will most importantly support staff and our communities going into the winter. From a capacity perspective, there's bespoke plans around surge for critical care and paediatric respiratory, recently called for by Welsh Government as well, but that's a plank of our capacity element. We have and we continue to deploy, but also test our risk assess models for how we board and use that boarding facility in terms of the safety flow model work. But also we are looking at, from a capacity perspective, we have a plan around additional body storage, 58, and obviously capacity in place from some of our community hospital our bed pool model that's been that's evaluating well. So there's some of the headlines under the capacity theme. In terms of processing power, this is really making sure that we are targeting expertise and decision making to where it needs to go, and being really clear on some of the pathways. So this is about how we're rostering senior decision makers. It's about some of the nurse-led frailty models, enhanced and multidisciplinary capacity at the front door, but also some high volume pathways, so fractured neck of femur, chest pain pathways that are being developed as well. An important component of both the processing power and capacity theme really is the work that's been referenced a few times around the patient safety events that Andy and Linda and others have been leading. The sort of rapid and sprint methodology interventions into so far the Royal Gwent, St Willis and YYF, to really unblock and facilitate facilitate the discharge or the transfer on of patients to where they are most appropriately cared for in their next phase. And we are, Linda and other colleagues are working up a plan for how that becomes an important plank of our winter response in terms of a regular beat of intervention and focus over the next few months. Other interventions in terms of keeping that focus and on both quality and safety, but also on flow, is around the improved use of safety huddles to identify risk and action. The day before discharge planning, working very heavily with community colleagues to identify patients and put into the community. And also a really big theme in the plan, you'll see more detail around both workforce and communication. So the workforce about the recruitment and retention actions, but also the well-being and the comms actions as well, so that we can enhance and do quite purposeful activity from a comms perspective, both internally and externally. In terms of the financial implications, I've previously touched on the fact that there's some RIF slippage that is supporting a number of actions, and this is just to note as well, we're trying to build sustainable solutions for our urgent emergency care system. So the majority of these initiatives are recurrent in funding in nature as well. So 2.6 million via the RIF, and you'll see the schedule of how that's deployed. Directly 1.5 coming into the health board, but clearly the system is benefiting from the totality. For example, the WAST investment in the Forwards vehicle. And then finally, I just want to touch on some of the risks. Industrial action is a real risk. The junior doctors are currently out to ballot closing in the middle of December. So assuming that goes the way I think we're all expecting, it's likely we'll have up to 72-hour strikes in January, which we'll have to clearly plan for, and that planning is already underway. And there's also risks that you'll note from the plan. This isn't about opening more beds plan, partly due to issues we've raised before in terms of our ability to staff safely, and we know we've got patients in beds who don't need to be there, and hence the work of the patient safety team. But we are obviously planning detailed sort of surge plans for in extremis if and when we would need to open capacity or reassign capacity from existing, whether that be planned care capacity or how we use some of the capacity we're liberating through patient safety. So that's being worked up as an in extremis part of our escalation plan. And then finally, I think I said finally on risks, but finally we've got some indicators to assess whether we are being effective in delivery of the plan included, and oversight, just to give you assurance, obviously the partnership interventions oversight will be via the GASP, the adult strategic partnership, through to the leadership group, and internally in AB through the ops team into executive team. So I'll pause there, Chair, and happy to take any questions.
Thank you. Thank you.
Well, I'm just wondered what we need to do to really alert the community about the challenges, because when you look at page 178 to 1558, that's on the right-hand side, those challenges, we haven't got the winter plan started yet, are immense, with challenges for social care, community care. We've got 300 to 350. We've got emergency department, surgical capacity, enhanced care, medical rotas, agency banks, staff GP practice challenges, and I mean those are. And then you've got the doctors' strike on top. I mean, we're already in a state of emergency, I would have thought. So I just wondered what messaging do we need to alert the community that we are already in a fragile state. I'm not sure what the colour rating is of the different sort of position statements, but I just wonder, you know, looking at that list, I mean, that is incredibly worrying in itself. Now we've got a problem coming in, so I'm just wondering what are your thoughts about what key messages do we need to get out to the community to make them aware that it's going to be an incredibly tough time, a fragile time, and what part people can play to support that. And are we talking about the wording? I didn't quite understand. There are approximately 303 medically optimised patients in our hospital beds at any one time. What does medically optimised? Because it's the wording there. With discharge dates that are delayed. So we've got already 300 to 350 people in hospital who shouldn't be there, which means that 300 to 350 people who could be in hospital can't access the hospital. So we're already in that position. So I'm just wondering.
Do you want me to answer the bit about the medically optimised, Hannah? Would that be helpful?
Thank you.
Paul, it's that they finished their acute medical care episode. So they need to move either, ladies in the corner probably support that, to another care facility within the health board. They're in the wrong bed, or they need to go either to a social care partner or home with support, but their acute episode is completed. They no longer need medical care on an acute basis.
Yeah, but even I'm just talking about the numbers. I mean,
oh yeah, no, it's
in itself.
The patient safety events on the sites that we've been conducting have illuminated this significantly. Going around with our social care partners, I think it's been a bit of an eye opener for them as well.
Well, that's helpful, but we're still in a position where we've got people in the beds.
We have, which is why we're doing those exercises. The one at the Gwent today, I'm missing that today, so it's partly relief for me, in all honesty. But we're doing them once a month at the moment, and we're going to replicate that across YYF and Neville Hall as well. It's to keep the rhythm and the beat and the turnover. In fairness, the Royal Gwent's discharges have increased reasonably significantly on the basis of a different cadence, a different beat, if you wish. But it's still going to be an almighty ask to maintain.
The issue is whether you've got 300, 350. If they then helped and supported back home, for example, you're still going to have a flurry of others coming in to fill the.
Well, I think what we're seeing again with our social care partners is we couldn't do these exercises more often than monthly because we are consuming their capacity almost immediately by doing this sort of more bespoke work.
Right. I'm looking at I suppose what it said about staff shortages in social care and community services.
Yeah.
What we're looking at is a perfect already developed before we've even come into the potential snowstorm of the winter.
Yeah. And I think that's the reality of some of the challenges we talk about a number of times here in committees around where the risks and challenges in workforce sort of are manifesting across the system with those numbers. Medically optimised delayed discharges, we've got various names, but basically they're people who don't need to be where they currently are. And it is about some of the work that we heard about at the start of the meeting about how we do things differently and really assessing what the right pathway is for those patients. On the communication piece, and I mean, I can see Karen's on the call as well. That's why the comms, I mean, I sort of skirted over it, but that purposeful and meaningful communications is going to be key. Personally, and others who are expertise in this area will know more about the evidence of what works, what doesn't. We do know, don't we, that in COVID, when we got the comms right, both nationally and locally, was really powerful. So there is, and I know, as said Karen, with colleagues across Wales, we'll be working on how we align national messaging around challenges with local, but really important that it's in our messaging. We talk about how how and what people should be doing to best look after themselves, vaccinate, get their vaccinations, supporting each other, rather than just the don't come to A&E. So it's really important we learn from what's worked and what hasn't worked in the past. But it will be a challenge to get that message right, because we often see, don't we, across social media and the media, messages about the pressure the NHS is under.
Yeah, because I've interested in many GP practices experience in workforce sustainability challenges. So people would normally contact, do the usual, sort of go down the list of do it yourself. If you can't, go to the pharmacy, but if you can't access the GP, you'll go to ED. So I think there's some work we need to do on that to try and help and support the whole system.
So I just want to kind of share my reflections of the top three things that worries me the most. This is one of them, as you can imagine. Our urgent care system is under pressure every day, let alone when we're going into the winter. And the winter plan is to try to make sure we try to mitigate the extra demand we'll see and the type of demand we'll see. And as you know, through the financial discussion and the quality and safety discussion, having extra capacity open that you can't staff is a risk in itself. So trying to balance the decision about the right sizing of the capacity in the context of spreading your workforce within and the money, when you know there's 300 patients who shouldn't be in those, it is a fine balance. But, I think what we're trying to understand is unless you can get those patients out, they will still keep coming in.
Yes.
We will have nowhere to put them.
Absolutely, yeah.
We end up boarding them all over the hospital in corridors, day rooms, which is absolutely awful. So we all believe that the biggest show in town on this is to get those 300 patients out of hospital that we know is not the right place for them, and try to give them the right support, either in home or another setting. And then the work that, as we mentioned, Andy and Linda have been doing, and the teams working with the partners, it seems to have had the biggest impact. And we are looking about, because it is sometimes having the right people who know the system and know what's out there, with the feeling empowered to make decisions, makes things happen. But you haven't got the capacity to do that every day at the minute. So we're trying to look in a different way as we go into the winter than just open another 2 wards that we will fill up with another 60 patients who will sit there for longer than they need to. But it just feels a risky position to not, or we always open extra capacity in the winter, and the current plans are we not. We are looking about what's those contingency plans if we need to, because we believe the right intervention is to focus on all the discharge work. But we are reliant. It's such a complex system, and we have done so many things. The bit that I'm struggling with, we have taken, so I was thinking pharmacy at the front door, therapies at the front door. We've introduced an SDEC, we've got frailty pilots, but our system is still under, and all of those have individually got evaluation, they're making a difference. The work we just heard about the CRT, but our system is still under significant pressure. So trying to, and we know that we are still bringing people into hospital, that lots of people will say we should not be bringing in. There was probably somebody last night when I was looking at, they probably shouldn't have been coming into this hospital, but they came in. So we know there's work to be done right away, but none of them are really quick. We've been battling this for many years, haven't we? But so I just think, that for me is that balance between capacity expansion versus really trying to make a difference on the discharges, where we currently are in terms of getting the right balance between those two, with the capacity that we've got and the processing power, which Hannah refers to. We try to look about, let's free up people to put more into the processing power, which we know has an impact. So I just thought I wanted to share that. It's a fine balance for us in terms of, those opportunities.
Is there anything we can do to help you as a board? Is this just a Gwent-wide problem, or is it
it's absolutely
else? So therefore, always messaging will be therefore an important part of this. I think that it's
no, we get hammered. So everyone knows I'm really passionate about ambulance delays. I'm constantly hammering about it because of the community risk. We get a dashboard from EASC every single week, which I study with interest. Within the last 11 weeks, nearly every week, we've got the second lowest handover rate across Wales. Cardiff is the best, because that doesn't make ours right, because I think that was awful, and there are some weeks we are, but every health board is experiencing those pressures right across the system. With, I know Tab Morgannwg, one of their hospitals is half of this full of patients delayed waiting to go home.
So it's a systematic problem, not just one for us.
Yeah.
I think it is complicated for us with 5 local
I
authorities.
would say that the principles are exactly the same across each health board. The nuances by local authority are what make it even more complex for us, perhaps.
Yes, I agree.
It's the same in England. It's no different.
No. Rob?
Yeah, it's probably important for the board to be aware of the pressures now in terms of potential patient safety and financial position on this, as well as all the other issues that's picked up, particularly through what Nick's just said. So just for information, there's over £2 million riding on closing beds and releasing costs to achieve our current financial forecast. If the proposals put forward in the winter plan don't deliver, and we have to open our surge bed capacity or hold it where it is, the delayed transfers care figure have been consistent all year. They reported through the finance report all year. So it is about how we move from where we are now to a better position, and then that better position gives us the heading for the contingency. The use of that contingency competes with our financial forecast. So just making sure everybody's aware of the wider implications of this. It is quite a challenge, obviously.
Yeah.
So I was going to raise it in the performance around the in the performance report around the people that should us in our hospitals and the patient safety team visits, which I understand why you're doing them. I suppose what I'm struggling with a bit is, and you, as you say, that's additional capacity. And while you're doing those, you're not doing something else that perhaps you should be doing. I suppose what I'm struggling with is why that we don't want to be in a position where people are almost like waiting for you to come in to do those visits, i.e. going back to what we were talking about, the health and safety. So it's not about that team doing it. And I just would like to know, might not be for today, Anne, but I'd like to know how are we doing to make sure that when we go into those areas, people are learning and understanding that they have that power to do it. So, that's what's really worrying me, because otherwise, carry on, you could increase them because you have to, the visits, but that doesn't necessarily mean it's going to actually change.
So one of the benefits we've found is the collaboration. Again, there's stronger collaboration between medical and nursing teams, and it's an educational tool almost at the same time of explaining to them the offer that's available by local authority. It's so complex that it's difficult to understand by these teams. So we've provided them with prompts now to ask by locality, is this service available? Is this service available? They haven't been doing that consistently because they are wholly reliant on a blunt process, if you wish, of waiting for local authority partners to come rather than proactively asking the questions. Mm-hmm. So that bit of, if you want an educational exercise, is embedding well, which is probably why we're seeing a little bit of greater sort of discharge activity now, because people are proactively looking for the opportunity more. Okay. Particularly nursing colleagues, in fact.
Yeah. So, sorry, I was just interested to know, sort of, once you have that safety visit, I know it will depend on the care that needs to be provided, but are we seeing then those patients being released out into the community or back?
Yes.
Very quick, 48, but quite quickly rather than waiting for another week before it happens.
If you look at the data after the patient safety events, you can see a spike in discharges that then starts to tail off between patient safety events. One of the things we found is that ward managers were becoming disempowered around discharge, and we need to be really clear that, whilst there are a number that are delayed by local authority, there are some that are delayed by us because of our reticence to send them back to an environment we don't understand. And, I've started talking in a different language and talking about patient transfers, care back to home and the primary care. Because actually that's what we're doing. We are still accountable and responsible as a health board, so we're not discharging them completely from our care. We're transferring them to an environment that's safer. It's going to meet their experience needs more, and actually is closer to their family. And in most cases, back to a clinician who knows them best. And I think it's changing language, expectation. It's upskilling our staff to say, actually, you can take ownership for this. We looked at how we can roll out criteria-led discharge, and that's one of our pieces of work is actually, rather than saying a doctor's got to sign this off, once the doctor said they're medically fit, let the nurses and therapists think about how we do that on a criteria basis. So lots of work to be done.
So what's happening up in So how can we really push that?
It's about rationalising, again, a constrained workforce and infrastructure to try and generate those models on a more consistent basis.
But it's empowerment as well, because
Well, the culture is right up the road.
you're supposed to have
It's all about culture.
Day one, and people understand that if that criteria is met, then, you know, then people go home with support. And I find it, you know, we just need to get back to empowering the staff. And I think certainly we've seen major improvements, but nevertheless, it's still a very serious problem, particularly for the individuals who are caught up. David?
Part of this plan is involved a timely and appropriate transfer of people out to the right place, whether that's home or ELGHs, community hospitals. I know in the past we've had some concerns about how the intersite transfer services are working and our ability to actually step people up and do what's our system. Are we in a better place this year for that? Are we happy and confident that that transfer mechanism is going to work timely and appropriately? Sets out.
I guess, so my honest answer is I don't know, but the fact that that's come through the operational teams where they've been testing it, I don't recall it being raised in the workshops as a significant risk or issue, but I think we can check that.
So Andy might want to come in as well, but so I think in terms of a step up, I think we've addressed a lot of the issues we had when somebody's care escalates and needs to come from an ELGH to the Grange. I haven't picked up as many issues or incidents.
We have specific incidents which require a specific response rather than a general problem step ups.
I think we still have issues with our step down from the Grange to the, I think it is better, but I still think we've got a lot of work to do because there are still times where there may be, you know, transport availability, and we are so dependent on transport to move people out of the Grange. It does seem better, but I think that it is still one of our priority areas we are working on.
We've got a review underway of the step down. We're stepping too many patients down. We're using it as a default option, not thinking about discharge. Yeah. So there is a patient safety event at the Grange next week, and that'll be one of the things. Profile of discharges through the day, but also that bit about actually step down the right option. Could something else be offered? And I think in that context, the step down transport, you know, we can conduct that review.
Yeah, the broad principle is that the step down patients need to be identified as early as possible and then matched with resource to transport them. And that's what we're not getting right at the moment, if that helps.
Any further questions and comments? I think it's critical, particularly bearing in mind the success or otherwise of last year's winter plan, that we get very regular reports on whether or not these plans are working so that we can take the necessary action just if that's required. And I think that it will be very interesting for this board to see the consequences early of the pathway reviews and what we are intending to achieve and how that changes the balance of support within community and within the hospitals themselves. So I think that we need very regular reports on, is this working? What are we going to do about it if it isn't? Which I know gets very operational, but we don't want to be in the same position.
I think as well, just going back to the report that Linda presented on Twice Front about how they're going to do those weekly reports. I think it was January, Linda said to start, so how we, as well as our hard metrics.
And I just add to, so we've also, in terms of the sessions we've got planned in December, we've agreed we'll use one of those to particularly do like a board development briefing session on urgent care. Things so we can go into these issues in a bit more detail and update you on where we are with some of these. So I think so that'll be quite helpful, you know, to where we are going in January. Recognising the complexities of the whole system work that we do.
Thank you. And just to note that from the Planning and Population Health Committee, we agreed to escalate further the issue of people not taking up their COVID-19 or flu vaccinations. I know that it has increased in risk, but we felt that it needed attention of the board for that. So I know Tracy's taking that forward, given even greater extra boost, but it's really important. And that's part of the messaging that has to come from the board meeting. Thank you. Thanks very much for that. Lost my agenda. The strategic equality plan.
Thank you.
Thank you.
Non should be joining us for this item. Non is our equality, diversity, and inclusion lead, and has dependency on putting this together, and also the consultation and engagement plan. So be aware that as part of our public sector equality duty, we're required to set equality objectives at least every 4 years. Previous reports have come to board in terms of progress against those objectives. We last published our objectives in March 20, and now we are working towards new refreshed objectives to be published at the end of April 2024. But before finalising our plan and our objectives, we are undertaking a programme of consultation and engagement. Non is set out in the paper, and the approach, which includes consultation with staff by surveys and our various staff networks. It also will use a varied sources of data in terms of looking at the evidence we have available, and also external consultation with the public, working with us, and also an external survey. There's an action plan contained within the paper, and we are making good progress in terms of pre-consultation. We have draft objectives, which we launch on the 4th of December, and they will be further consulted upon, and they will centre on the concept of patients, people and population with an objective for each category and corresponding actions. We're on track with a plan. We've already undertaken workshops and focus groups with LICE in total, equality chat cafes for staff, and conducted workshops via the staff networks. However, it is worth noting that resources are tight, so this programme of work is taking a precedent over some of our other work in terms of equality, diversity and inclusion, as Non is very thankfully, but unfortunately our single lead, very much standalone in terms of developing, although we are working on that internally, and we've got some support coming in for Non shortly. So the paper sets out some indicative costs with a plan, direct costs mainly in terms of translation, not only into Welsh, but if there is requests to translate into any minority language, we're obliged to act on that. But also indirect costs in terms of non-time and time with those colleagues who will support us internally and externally. And we're also asked to note the plan and provide any comments or suggestions in terms of the next steps of the consultation and engagement programme, and Non's available to answer any questions.
Thank you very much. Do you wish to add something, Non?
No, thank you, Chair. I think Sarah covered that very well, but happy to take any questions or comments from colleagues.
Thank you. Any questions or comments? Well, you've confounded them all. So it's perfect. There you go. Are we content to adopt it? And we will monitor this very, very carefully, as it's so vitally important to us all. So, oh, well, thank you, Non. This is most unusual that there are no questions.
Thank you.
So, when will you be able to come back with your first?
Okay, we will be back in March with the new objectives for approval, and happy to reach out if people want to be involved in the consultation and engagement that we've got underway. We can share that with board members so they can participate.
Lovely. Thank you.
Thank you.
Thank you very much.
Diolch, Non.
Diolch.
If we can move on to 3.6, the patient safety incident reporting and management policy. Jenny?
Thank you, Chair.
So this is the Health Board's new patient safety incident reporting policy. It works in line with the new national policy that was released in May of this year. The Health Board has not revised its policy since 2012, so quite a significant period of time since the last revision of the policy. A number of things have happened clearly over that period of time, apart from me arriving, including, we have a new set of legislation in relation to the duty of quality, duty of candour, that places new and additional duties on the Health Board in terms of public transparency, but also engagement with families. There's been a change in the methodology around reporting nationally reportable incidents, so much more around judgment and analysis, working on understanding of the opportunity to learn and the impact of the safety issue, rather than it being a list of triggers that need to be reported against. It also works in line with something called Safety 2 and Just Culture. So there's been a big sea change, particularly in England, that Wales is adopting, where safety and quality becomes much more about the thematic learning that you can undertake and embedding learning into more of our everyday approaches and activity, but creating a culture where staff feel free to raise concerns, as in the paper we had earlier, but also that just culture about if there are issues, that those are taken through the appropriate routes proportionately. So much more around that sort of just culture. We will be alongside this. We are working on a learning framework to describe how we learn as a health board, what that means and where that's reported. So that will be coming through to PQSOC in due course. We also know that the way in which incidents are investigated is changing. So there's been, again, a sea change globally, actually, in terms of a thematic learning approach, proportionate and appropriate investigation, rather than detailed root cause analysis in every case, where that won't extrapolate learning. We're already working within the new, what England calls the PISA framework, but looking at how we look at issues thematically. Peter and myself and James have all had never events we've looked at thematically. We've been looking at deteriorating patients from a thematic perspective, and Peter's been leading some work around delays in diagnosis in particular, and how we draw up that learning into improvement programmes that we can turn into QI opportunities. We're working closely with the Welsh risk pools. You know that they now take the opportunity to fine us if we're not identify the learning, particularly from cases that go through Welsh risk pool. That's a mouthful. And making sure that we are able to robustly demonstrate that learning so we avoid those fines. And I'm glad to say that we've provided significant assurance in recent times to reduce that risk. But one of the things that's at the heart of the new policy in particular is how we involve patients and families in the investigation process. One of the things we've learned through a couple of investigations this year is that families have felt very excluded from investigation processes. They felt that they haven't had an opportunity to comment on the content and what we're investigating, and actually have felt that we are hiding something rather than being transparent. And what this does with the duty of candour is place right at the beginning of the process a conversation with the family to say, this is what we're going to investigate and look at, and what are your views? What's your understanding of what happened, and what does that mean? But also patients themselves, of course, in many cases, but putting them right back at the heart of the investigation process, but also making sure that we share the learning with them so they can see that we have learned, we have improved, we have done things differently. We have, in the cover paper, provided you with an opportunity to see what the differences are. So we've done that gap analysis just for easy reference. And the only other thing I'll add is that we have moved away from what I would call perhaps a slightly old-fashioned system of looking at what we used to call Red 1 and Red 2 investigations, so 2 levels, we now talk about levels of harm. So we talk about moderate and severe rather than red 1 and red 2, because just because something's moderate doesn't mean it's less important. Actually, sometimes the moderate incidents are our near misses and our opportunity to prevent recurrence in the future. So this policy very much aligns with our change in approach. It aligns with national policy, but also the global policy on where patient safety and learning is going.
Thank you. Very helpful. Thank you very much. Paul?
Can I ask about the investigation officer? Is that a clinician? Is it a separate, trained independent sort of investigator? Because I'm looking at the workload involved in one of these sort of, if you look at the, I think it's page 252 or 558, I mean, it's an incredible amount of work for anyone undertaking this, which is incredibly time consuming. Absolutely right if it's needs to be done. I'm just trying to work out in terms of the proportionality and the what's involved as to how that features up.
So in most cases for patient safety incidents and complaints, those investigating officers will be frontline clinical staff at varying levels. We do provide training, we do provide support, but I think the change we'll bring about is I do want to create through the realignment of the quality patient safety resources some very specific investigation officers who are very highly trained in very complex investigations. But in reality, we will have a whole host of people investigating. I think what's important is the level of investigation and making sure it's not a 50-page root cause analysis in every case, that it's proportionate to the learning and the seriousness, but also that we support and coach those people through the process. So my team work very hard to do that now. We want to make sure we do more of that, to make sure we've got the right training, but also to use different methodologies like thematic reviews, like concise investigations, to make sure that we're doing it in a way that reduces the burden. Because if I've been through with families a 50-page RC root cause analysis report, and they don't understand it. And actually, you have to ask yourself, for whose benefit is the investigation and that level of depth, when actually sometimes it can be said in 10 pages, quite concisely, quite openly and transparently, that really everybody can understand, but that we get the learning. So yes, Paul, there are many people in the organisation who will be IOs. We prepare them as well as we can, but I think that the change in how we investigate is going to be really important to that.
My worry is reading what's involved, the amount of time taking up to undertake this. So what happens in the meantime with their work, the sort of day job, should we say, as opposed to this, which is a separate part of it?
Yeah, I mean, Paul, they'll be doing that, and what we can't do though is reduce. We can't take away the accountability and responsibility for all staff to be part of a patient safety process, because actually we need them all engaged. And if for example we put 50 separate investigators in, actually the accountability and responsibility for preventing recurrence, will be taken away, and actually that won't be seen and felt by clinicians on the ground. So I completely agree that we need to manage the burden, but we need to make sure that our frontline clinicians do have that opportunity. Many of them want to investigate. They enjoy that. There are many doctors we have with job plans that include quality and safety activity. And I think it's about using our resource intelligently, but making sure the support's in place.
It's an area where we're trying to develop, as Jenny's already said, frontline clinicians who are interested in these pieces of work, and it is duly useful in that they've got a background knowledge and they resonate better with the clinicians as well. So you get a far cleaner interpretation of events, honest interpretation.
Yeah, absolutely.
Thank you. And mostly it's comment rather than question, because I think that the reality is that any of these incidents are an opportunity for us not to do it again. Mm-hmm. So we need to be learning. So I think it's the changes in the policy, I think, are really good. It's just a question for me on how we define the criteria, I suppose, for those cases where somebody just wants a conversation or 1 page or 10 pages or 50 pages. So how do our staff understand exactly what they need to deliver in terms of the investigation to A, suit the family, but B, to understand what the learning is and how do we generate that kind of shared culture amongst the staff so that the policy isn't just for us and for the people who are doing the investigating.
So if I talk for the most moderate and severe, because there will be, we have about 25,000 incidents reported a year, of which a significant proportion are patient safety issues, but many of those will be low harm or no harm. The one thing we have to get better at doing is using data, because it's our repository for learning and extracting for that. We are going to be having a learning forum, so we want to get staff involved in learning and sharing, because even if something happens in maternity, there might be thematic learning that's relevant for COTI or for older people's care. You know, there are common themes around system, process, culture that can actually relate across. And I think that, you know, for us, it's about how we work with and support people, but engage them in the learning and how we understand what the family wants and needs. Some of that will be about the PAL service, you know, and getting their engagement really early in the process. We have to get better at the duty of candor conversations. It's very early days for Wales, but I think those are really pivotal in understanding what the opportunity is. And some families want really complex, detailed information. Others just say, I just want to know you're not going to do it again. Are you going to learn? And, you know, sometimes that's all you need to provide to them. And that can be verbal, it can be, you know, it can be in a number of different ways.
Are there any further comments? Gavin?
This is really good. I think one of the things that stood out to me, the more and more digital technology plays a role in how we treat patients and how we manage patients and whatever. I'm really glad to see there's some bits in here that call out specific issues with technology as a type of incident that might lead to patient harm or a need for an investigation. One of the things I wanted to just sort of comment on to be a bit careful about is the way we've worded this in here is about a failure of an IT system or a failure of a national system. And that tends to lead people to thinking it's a system that's not available, that's offline because of a fault, a bug in the system that means something hasn't been calculated correctly. Whereas actually some of the biggest problems with digital and technology systems is the usability of the system. And the fact that most systems into every organisation have not been tested with people who should be using it, not user friendly. They are not designed to stop people making mistakes while using it. I think we should explicitly call out that the usability of a system is a thing in its own right and is a problem that should be keeping an eye on. We've seen many examples in the press over the last couple of months of poor IT systems deployed into health services in England, where that's led to answers not being sent to patients and patients not being followed up on. And that isn't a fault in the system, that's a fault in the usability of the system. And if those systems have not been designed to be clear, we should include that as a specific thing. The usability is as important as whether it's available or not.
So we do in reality, David, the words in there are from the national policy, but I will feed it back to the national lead around making sure that that isn't linear. And that's the point about judgment. Yeah. So we will make that judgment locally because it's implicit to our discussions, particularly around user error as well. That's the other issue. But those are the words from the national criteria, but I will feed it back to the national lead.
Thank you. I think that's a very important point, David. Thank you for that. Ewan, and then
I was going to say.
All right.
Just on that, just to provide assurance to the board, we do have a clinical assurance process which is in place for all digital services. Our safety officer goes through each clinical system. She does a hazard log, a risk review, and clinical safety workshops. And just very recently, we've delayed an implementation of one of our systems because of the clinical risk that it would impact to the organisation. So I think it's important that we reflect that. Yeah. In the documentation that's been presented.
But I think it's that is good. It's good we do that. I don't believe that goes far enough. In most systems we put in place, we don't do usability testing. They're not designed around the needs of users. They're designed by companies and technologists building a piece of software. And if they were designed properly for users, we would not have to go through that process. And I will guarantee you that every single one of those systems in England that's been reported in the press has gone through exactly the same process as that to check whether they're valid or not. And then that's led to millions of letters not being sent and numerous other issues. Because we don't design systems around the needs of users, because we just buy them and put them in place, and they're not telling you, it leads to poor usability. And that's the problem. It's poor usability around the system.
Yeah, do agree with that. And I think the whole user-centred design for digital is a really area that NHS Wales needs to look at. And the centre services.
A very good example. So
yes, definitely.
Yeah, we finished on this particular point. A wider point on policies. It's something that keeps coming up in every audit report has, where's the policy for this? Where's the procedure for this? And I think we've picked it up aboard a few times as well. So how do we gain assurance there aren't more like this out there that are 11 years old, is it, or 12 years old since we last reviewed it? You know, what are those policies do we need in place? When should they be? That kind of thing. And that assurance isn't there, you know, as I say, every audit report we get mentions some kind of policy.
Yes. There are a number of old policies. So we've recently had an audit on risk management. It was limited, there's an improvement plan underway, and we'll bring forward an update audit committee on that. There's an update on our governance improvement priorities on next week's meeting anyway. Policies have been included within that. So we will see reporting come through.
Yeah,
but there is
just putting it out into the board of all, here are all our policies and what the dates are on those.
I think there's some work for us to do in validating that. I don't think we can provide that at this
No,
absolutely. It needs to form part of some corporate governance type metrics, really. Yeah, so there's work for us to do.
Thank you. Any further comments? Okay, thank you very much for that. 3.7, long-term strategy.
Thanks, Chair. I'm hoping this may be brief as we've had a development session on it. It's been to the planning committee. And also since then to note, it was referenced, I think, in the Chair's update at the beginning around the session we had as an RPB. Yeah. So what this is just asking is to approve the approach we previously talked about. So I just wanted to call out some of the themes that as we are engaging on the approach that have emerged. So I think the big thing for me is around the linkage between PSB strategy, vision, goals, ambition, RPB strategy, visions, goals, ambition, and then the organisation sort of ditto and the interrelationship between the two and us as an organisation, our role within that context, both but as a provider of services, but as a commissioner and with our population health responsibilities as well. So that has been, I think, in the conversation we've had to date, an important theme. To as well, we're asking sort of the formal sign-off of the governance approach we have previously tested, but I wanted to give wider board members who aren't in that strategy steering group just the assurance that we have, as of I think it was just yesterday with the Michelle in Rani's team, agreed how we will use the strategic briefing sessions in the corporate calendar to bring everybody to test, shape, challenge the work that's coming through the programme. So yes, we've got the governance structure, but alongside that, there'll be opportunity for wider board members to remain very close to this work, and you can get assurance or otherwise that it's meeting your needs. The first session of the steering group, I should say, is on the 15th of December. The key next step, and the steering group have an important role in shaping that, is the development of the engagement materials and signing off those. So I'll pause there. I'm happy to take any questions, recognising if they're not reluctant.
Thank you. Thank you very much for that, Anna. Are there any questions, further comments? We have seen this before and we've had a chance to discuss it. So I'm glad to see the changes that have been made, and we look forward to the first report coming from the engagement proposal. Okay, thank you. Might I suggest, before we all freeze to death completely, that we have half an hour break for some lunch and whatever else, and come back at 10 to 1.
do an urgent service change, particularly around the stroke rehab service, recognising that through Clinical Futures that the hazard acute stroke service was consolidated onto the Grange. So at that meeting, the board recognised the particular circumstances and approved. Much planning has taken place, and Tracy's going to talk you through a bit of that now. But the board did ask for an update and had a couple of queries on engagement, impact on COTI, clarity on beds, savings, etc. So you have a paper here, but Tracy does have a few slides just to draw out some of the key points of the paper. So if that's okay, I'll hand over to Tracy to talk us through these slides.
Thanks, Hannah, and thanks everybody for allowing me to come in this afternoon just to provide an update. I thought I'd start just to go back really with some background and some context of where we are, just leading on from Hannah's conversation. So as you're aware, we had significant workforce challenges within the stroke service, predominantly across the medical and therapy teams, albeit some of our nursing sites, some of our sites with our nursing teams have been challenged, but I think that's more of a generic issue. The GIRF team came in then back in 2022 and provided us with a number of recommendations, which also talked about sustainable services. We had difficulties in terms of the estate and the protection of therapy areas right the way across. And as some of the work that we did as part of the scoping of this just provided us with a demonstration that our demand for stroke predominantly sits within the Newport and Caerphilly boroughs, albeit all boroughs actually use this service. So we brought a paper to the executive team in the summer, identifying the need to address the concerns with our recruitment and our vacancies, and proposed a consolidation of services, and took the request to work through an option appraisal of how we could address this in the most safe and sustainable manner on an urgent service collapse. The outcome of that, which includes engagement with all of the teams, the medical, the nursing, therapies, and trade unions, and the weighting came through that we would maintain one acute site, which is obviously the HASU at the Grange, and then consolidate our rehabilitation services from 3 sites down to 1. And then the confirmed site that came through from that was that we'd consolidate down onto YYF. Next slide, please. Thank you. So by doing this and bringing us down onto a 2 site, it aligned with the recommendations that came from the GIRF review. It provided us with an opportunity to test a centre of excellence, which would hope that would assist us with improving our recruitment. The challenges that we had, particularly in the north, was recruiting to stroke consultants, and the feedback from candidates that were applying for jobs as other parts of the health board was just the distance. The proposal in centralising the services offered us the opportunity to reduce our bed take by 8 beds, and that aligns with the needs of the service and the demand that was mapped throughout the process. Next slide, please. Thank you. So as part of the proposal, we undertook a communication and engagement process. We had we've had throughout the whole implementation process, weekly newsletters to go out to our staff groups. Whilst we've engaged with staff through one-to-ones and through formal and informal meetings, we've recognised in the pace of change that this proposal has moved at, and the need to keep staff forefront of every decision. The newsletters have been quite well received, and we've had quite a lot of operational feedback for those weekly updates. The stakeholder map identified the communication both internally and externally, but recognising that we were undertaking this under an urgent service collapse. So it was more to keep people formally notified of this change. And we've maintained our engagement with LICE throughout, and the planning team have had regular meetings with the LICE team. So the plan was that we would implement this temporary urgent change as of Monday, the 27th of November, which is obviously next week. But there is still a need then for the longer term plan, taking into account the recommendations of GIRF and understanding how we can provide a long-term sustainable service. And as I said, we've engaged with trade union partnerships and the local negotiating committee throughout. Next slide, please. Okay, this was just to provide you with an overview really of the timeframes and the milestones that we've achieved since bringing the paper to the executive team back in July. So we went through our formal consultation, our one-to-one meetings. We formally closed the consultation, and the consultation meetings we held over Teams, and I had over 120 people attend those meetings. So it just demonstrates the amount of engagement that we've had throughout with this. The staff have been absolutely amazing throughout. There is a number of challenges with any sort of service change, but their engagement, their passion, the commitment has been astonishing throughout the process. All of the staff that have been affected by this have actually received formal letters in terms of, in addition to the verbal updates that we've had throughout. And we've started the implementation of a phased approach since the beginning of November. Next slide. I thought it was important. There was a lot of conversation over the previous papers to just articulate the change of what this would mean, of what beds that we had previously within stroke and the care of the elderly service, and provide the assurance that we've maintained our capacity for our care of the elderly demand across the system, albeit those beds are now provided slightly differently across the 3 ELGH sites. So the net reduction throughout all of this change and consolidation is only, as indicated, of 8 stroke beds. We've maintained our care of the elderly capacity throughout the system. Next slide, please. Thank you. So the financial analysis with the consolidation is that the reduction in beds and the bringing the services together provides us with an opportunity of a saving of just over £600,000 per annum. And that's broken down between nursing, medical and ward assistants, ward clerks, etc. In order to achieve the full amount, it required us to actually reduce our bed capacity and change the consolidation. If we just move forward, we don't change our care of the elderly capacity, but we've just reduced our bed capacity by the 8, we will achieve the 400 savings from a nursing point of view, because we are physically removing that bay where we're providing, I'll come on to it now in terms of the therapy capacity, but because we are maintaining our care of the elderly capacity across the system, we've had to maintain the medical cover across the whole footprint. So our true cash release around this is going to be £400,000 because of we're running at around 110% occupancy, as you know, within the system at this moment in time with additional capacity. Next slide, please. Okay, so again, this is just provide the timescales of where we are. So the OCP has been completed. We're in the implementation stage. We have started to move our patients in a phased approach so that we caused as minimum as disruption as we possibly could to patients and staff. From the beginning of last week, any patients that were stepping from the Grange, from the Hazu, that required ongoing rehabilitation care in the south of the county was going straight to YYF, and we're repeating that pathway now with patients from in the north. There's all of the stroke rehabilitation patients that were on C5 East in the Royal Gwent, that their care would be required past December. We've repatriated those patients up to YYF. There were only 6 stroke patients on the ward. The rest of those patients on the ward are care of the elderly, and they've remained in the Royal Gwent Hospital. And at the moment, there were 10 patients in Neville Hall. The beginning of this week, we've moved 4, and by the end of this week, we'll have removed the remaining 6. So by the end of this week, we'll have no patients within Royal Gwent or Neville Hall that are requiring ongoing stroke rehabilitation care. And then patients that are requiring step down from Hazu at the Grange will automatically step down into YYF. Next slide, please. There's some benefits from the consolidation, and these were repeated within the GIRTH review. Within the ELGH sites, predominantly in Neville Hall, which is, I think, why we had the challenges from a recruitment point of view, we had a lone consultant. They were a lone stroke consultant working alongside a care of the elderly consultant. And from a stroke point of view, that's not proved attractive from a recruitment. By bringing them all together within this one site, we've now got 2 stroke wards that are co-located, and we've got a stroke team from a medical, nursing and a therapy point of view. So we've gone back out to advert for our stroke vacancy consultants, and we are pushing that opportunity for them to come to work in a co-located and collaborative approach. Psychology therapy input, because we were spread across 3 sites, they were only going into the sites once a week, and then the other 2 sites would have twice a week. By condensing our services onto one site, we've now got daily psychological therapy input going to our stroke patients. So there is an immediate impact and benefit to our teams. Working with our local authority partners, recognising that we will have all of the boroughs within YYF receiving stroke therapy. We didn't want our patients to be detrimentally impacted if they required ongoing care and support. So we've got agreement with our local authority partners that we will be utilising the trusted assessor model within YYF. We've now, since the beginning of November, had social workers based on the wards within YYF, and they are following the trusted assessor model. So regardless of where a patient lives, their needs will be met by the assessor model, and then will be dealt with within the local teams. And as I've said, there is an undeniable opportunity for us to improve our ability to recruit into the condensed model. Next slide, please. Okay, so these were just points that we wanted to make in terms of offering some consideration. So whilst there are benefits from the consolidation of the services, the CNRS team is still part of a wider ongoing review. The in-reach is easier for them because it's consolidated onto one site, but we know that CNRS, to manage patients actively within the community, requires a change in service and some wider support. So it hasn't addressed that wider review that's going on, but it does provide an opportunity for increased in-reach. There absolutely is an impact on YYF, as we've now got 55 stroke beds on that site instead of the original 15. And that has resulted in an adaptation and a realignment of our care of the elderly beds. What we've done as part of the implementation to minimise the impact on the patients that were in YYF is we've worked closely with the community team as part of their patient safety event, and any patients that we've needed to move out of Caerphilly, out of YYF, to create space for the stroke patients to come in, we've maintained as close, following the care close to home strategy, as close to home as possible. So if they've required care, they've either moved into the North Rumney Resource Centre or to St Wallace Hospital, and in some cases to YAB. And the patients we've moved are those that are medically fit and still waiting for either package of care or placement. So it's not had an impact on patients that were ongoing care of the elderly rehabilitation. The patient safety events, there's one ongoing again in the Royal Gwent today, and we did one in St Wallace yesterday. These are going to continue, not just to support the stroke reconfiguration, and as I said, it's been a real support for us, but it's about that wider system and trying to help support us move patients on to the next steps of their journeys in as timely way as possible. But I think what we've learned through this process is that we have been moving patients because of the congestion within our system. From a stroke point of view, we've got more than enough capacity to support our patients correctly within the centralised service. And next slide, please. Thank you. I thought that was the last one.
Thank you, Tracy. I'm happy to take. Thank you. Any questions?
Thank you, Chair. Thank you, Tracy. Just some additional comments really to Tracy. We had the stroke delivery group yesterday, which I chair, and we had some really helpful and useful discussion. I'm really kind of trying to focus on the benefits, really, in terms of what we will derive from this change. We know that by spreading the therapy resource across 3 rehabilitation centres, we've had huge challenges, really. And quality metrics related to stroke and therapy are all about therapy hours. And we had a really beneficial conversation about how we start to collect more meaningful outcomes for therapy. So not only do we know about the therapy hours that we provide for each stroke, each person recovering from stroke, but also we can start to measure the outcomes. And I think that's going to be really important if we want to see the benefit of this change, to understand the impact on outcomes. So that's something we've committed to do through the stroke delivery group, so we can understand that. The other thing as well, Tracy referred to community neuro rehab service, and they're our team in the community who take patients out of hospital when they're at that stage and ready for home-based rehab. Interestingly, as a result of the changes we've already made, that team has seen an increase in referrals to community to undertake early supported discharge. Whilst that's challenging to a degree, I see it as a clear indicator of success, that if we can achieve more early supported discharge for those patients, we can start to get people home sooner. And that's where care closer to home really starts, the rehab at home. So we've got to review the CNRS service, as Tracy indicated, and we've got to make sure that we don't become a victim of our own success and that we can manage the extra activity in the community. But for me, that's an early sign that this is the right thing to do. So just wanted to kind of add that to Tracy's presentation.
Thanks, Peter.
Louise?
Thank you, Chair. Yeah, I'd just like to acknowledge and thank Tracy and her team for all the hard work they've done around this particular agenda. It has from personal experience gone quite smoothly, and hopefully by the final move everything will be great. It's only one question I wanted to ask, and it was around the therapy rooms that were going to be used, the 5 beds that you bedrooms that you mentioned that have been highlighted as therapy space inside the paper. I'm just wondering, my concerns is that it won't be protected space, and that we might bed them overnight, and which then would compromise the impact on patients for rehab the following days or after the weekend and all this sort of stuff. So, which then links in with discussions we've had earlier about discharging people earlier so that we can free up beds and all that, and with the winter pressures. So, although I understand the need would be to, if it's a room, we would look to use it. It's just counterproductive when you're actually trying to maintain the level of discharge and people's rehab in order for them to go home. So I just wanted some reassurance around whether or not we're actually going to protect this space, because we had a very similar issue at GUH where the space was not protected, and it caused a delay in getting that area protected. So I just thought if we could, it's just a blip, so we don't have to go backwards rather than forwards, and we could get it all done before the move. I don't know who's in charge of that sort of stuff, but it was just something I observed from the paper that it wasn't named as a protected space. Thank you, Tracy.
No problem. So Louise, in terms of the 5 rooms, you're absolutely right. So we've taken a number of steps in terms of trying to put that level of protection and support in there. We all recognise the importance of maintaining that level of therapy and support to our patients, to make sure that they are actively supported and supported for their discharge. So we've split the 5 rooms. There are 2 at the foot of the one ward and 3 at the foot of the other ward. Those rooms have been decommissioned, in want of a better word, from a bed point of view. The ward allocation, the wards now have recorded as a 28-bedded ward and a 27-bedded ward, respectively, instead of the previous 30-bedded wards. And the kit is in those rooms and is stable from a therapy's point of view. I think with any occasion, as an organisation, when we go into escalation, unfortunately, we have made unpalatable decisions. And I would be remiss if I sat here and said it would be a never event. But every mitigation has been put into place to ensure that these are protected. And the steer that we've taken is that it requires an executive approval before anything can be changed from that approach, rather than it just being the decision of the overnight site team. So we've taken a lot of physical steps to make it unusable, and then we've got the escalation policies in place as we have with any sort of environment in the organisation. But I think it's going back to Peter's point, it's something that we're going to have to watch and monitor. From a stroke point of view, 55 beds is more than adequate to meet our demands and our needs. It's then more about the wider system challenges.
Okay, thank you very much, Tracy.
Thank you, Louise. Are there any further comments?
Yeah, just to acknowledge the teams have done, a huge amount of work in a short space of time to make this happen. And I think the reason it's gone well, I think that, we've picked up like the staff engagement, because we've had to move location for staff, but I think everybody agrees it's the right thing to do for the service and for the patient. So I think that's why, but I know, the team at YYF have been, the amount of work they put into this and reconfigured the wards to make sure they co-located, and hopefully will really help improve the HASO as well, and how the HASO works, because that front end stroke pathway is a priority for us as well to get better. So, I really am hoping that this will improve stroke services right across the patch. And just as an added, but when we were in the NHS Awards, one of the nominations was the work that the stroke have been doing with stroke survivors and peer support. And these individuals are really keen to go into the stroke rehab and work with current patients, and kind of shows what what the recovery can be. And I think having a centralised stroke rehab will strengthen that service as well. And I know linked to the psychology support really do help with recovery. So I thought I'd just share that one as well, just a bit of an added bonus.
Thanks, Nicola. Good. Are we happy to note this? Yeah. And we'll have a report back on success, I'm sure, for the future. So thank you very much, Tracy.
Thank you very much
for your hard work. Thank you.
Thank you. Thanks. Yeah. Bye.
Bye. 4.2, the nurse staffing level Wales Act annual. We seem to have one of these annual reports every month.
Yeah, there's the interim report, then there's the annual report. But I'll just pass to Linda for expediency.
Okay.
Yeah, thank you, Jenny. Thank you, Chair. So, as you see, the purpose of the report is to provide assurance to board on the nurse staffing levels for all wards within under Section 25B of the Act, and it's for the period of October 22 to September 23. I think it's quite pleasing to note it looks like we've potentially got to a position of some stability with regards to the requirements on our wards, and it's not previously there's been a lot of additional requirements being presented to board and which has been agreed. However, we do seem to hopefully managed to get to a position of stability. So in line with the Act, we've applied a triangulated methodology in order to determine our nurse staffing levels. And if I first just quickly refer to the spring calculation, so that's following the January acuity audit, whereby we acknowledged 6 wards potentially required some changes to the required establishments. However, 4 of those wards were affected by the stroke reconfiguration, so we felt it was pragmatic to leave those wards at the minute, not make any changes until the wards settle down, and then we will go back and review. The further 2 wards were one ward within surgery, where actually after we undertook the recalculation and triangulated methodology, they found that they actually needed a reduction in their staffing levels in one of their surgical wards, which gave us a cost saving of 102,695. There was a slight cost associated with one of our medical wards out at YYF in that we had to uplift a band 7 who was only 0.5 supernumerary status, and this Nurse Staffing Act clearly articulates that all band 7 nurses should be and have a supernumerary status within the ward. So there was a slight cost associated with that. Both those were agreed at Exec Board in August this year. So we then moved on to the autumn calculations, and they were following the acuity audits undertaken in June. And again, we We acknowledged a state of stability. We were still waiting for the outcome of the stroke reconfiguration. I think we're in a far more positive place in regards where we're at now with the stroke reconfiguration. So we will just look at the ward as outlined in the Act, because they've been repurposed, just to make sure that the establishments are fit for purpose and correct. The only other change to mention is around D2 West at the Royal Gwent Hospital. And again, following a recalculation, they noted a further reduction required in their staffing levels, which again resulted in a cost saving. There was no further amendments made to our paediatric wards or our gynaecology wards over the two recalculations. So board is asked to receive assurance that we're meeting our statutory requirement in line with the Staffing Act, and also in line with our statutory requirement to provide an annual report in order to articulate clearly what our staffing level Wales wards under section 25B should be. And happy to take any questions.
Thank you, Linda. That was very helpful. Any comments or questions? No? Got off lightly. There you go. Thank you very much.
Thank you. Bye-bye.
Bye-bye. Thanks. The Quality Performance and Outcomes report to Jenny, please.
Okay, thank you, Chair. So I will take this report as read because it's quite lengthy, but just a few little bits to highlight from me. So this is our first quality narrative report and clearly links with our priorities under the quality strategy and the duty of quality and the duty of candour. We've accompanying this report in future board meetings will also be a quality outcomes framework. We have seen that in draft at SOC, but we needed to do some tweaks before that was ready for public board, but that will be available in January. So we now have a set of metrics called our quality outcomes framework, which really set the data that we're going to monitor around quality, and that will be evolutionary. We are the first health board in Wales to have a quality outcomes framework for public reporting, which I think is fantastic, and we have shared that version with Welsh Government. We felt it was also important to tell the story of quality, and that's what the quality narrative report will do. It shouldn't be a surprise to PQSOC members because it encompasses all of the things we talk about in that committee around the pillars of quality and clearly the elements of quality that are now measured on an all Wales basis through the new national quality standards. As Peter said, within that, importantly, health and safety is included. So we've ensured that our reporting around quality is rounded to encompass all areas. We've also taken the opportunity to triangulate our learning. So you'll see, and this will develop as we develop our new learning framework, that we are constantly triangulating our data with the experience of our staff and patients. So trying to make sure that we understand what the data means in practice for our people. But the other thing that we have within here is a real opportunity to share some of and celebrate some of the success we've had, particularly with quality improvement and the Safe Care Collaborative, because it's really important we acknowledge the work that's underway to make sure we don't just learn, we actually put in the improvements in place. And I think it's a real opportunity to celebrate some of the work that's been done by Trish, my team, James' team and Peter's team, to really centre quality within this organisation. As ever, we're very ambitious. We want to get to a position where QI is built bottom up. So we have every team manager at band 7 and above trained in QI so they can own the future, they can identify the learning, they can prevent the currents and put the programmes in place. But in terms of the report, the bits I really, really want to commend to you are section 4, so I'm going to pick out a couple of sections, but section 4 really sets out the work we've done on patient experience and in particular some of the work we've done on Civica and volunteering. I'm really pleased to report that our overall satisfaction on Civica, and there's more to do as Civica is rolled out, is 80%, which is really pleasing given the position and the busyness of particularly our urgent care system. That's not to say there isn't learning and things to improve, but I think it's a really fantastic opportunity to celebrate the fantastic work our teams do, but also to highlight the work of our volunteers, which we've included here. because for many it's really, really important, particularly our end of life champions, our dementia champions who are out there every day supporting our clinical staff. And there are 292 volunteers registered, which is huge in terms of the opportunity that gives us. And in fact, we've turned a number of those now into staff, into volunteer to career roles, which give people an opportunity to get back into the workplace if they want to do so. The other two sections I'll mention briefly before taking any questions are section 5. So section 5 really highlights some of our areas of risk. It identifies the themes and the learning, and it also links that back to the Safer Care Collaborative. So I've talked already about nationally reportable incidents. You've had the policy today, but what's really important to me is 5.2, where we are picking up those themes and putting into place improvement programmes. And James, myself and Peter exec champion all of those improvement programmes through the Safe Care Collaborative to make sure we've got the right level of oversight, support and challenge to the actions we're taking. The only other section I'd highlight is just coming back to what Ewan said is section 6, which is our complaints. So you will know that I've reported previously to the board that we have been in a position where we had a number of aged complaints when I came into the health board. We had a system that didn't seem to be working in terms of timeliness of response and the right response to patients. We had an increase in numbers going to the Parliamentary and Health Service Ombudsman in Wales. And actually, what we've seen over the last year is a real reduction in over 12-month complaints. We've had significant effort from the divisions and from my team to really focus on that. Nicola signs off every complaint and we pick up the learning from each and every complaint to make sure that we are putting that into practice. Our 4 top themes, which probably don't come as a surprise, are delay in appointment waiting time transport, delay in treatment or assessment, incorrect or insufficient treatment or assessment, and communication, which we know is a huge theme. What we've done as a result of that is to reorganise the way we manage complaints. So we are much more focused now on answering the question, to being really focused on giving the response to the complaint that they want and need. We are very much more engaged in terms of those verbal conversations. We've also created the PALS team to create a different approach. When someone's unhappy, they don't need to pop a complaint in. They don't want to. Actually, our PALS team will be out there on the wards, able to meet with them and help them resolve it early. And that's much better. We know from the English PALS models that has a high level of satisfaction for people, both the patient and their family, in terms of getting an early response and resolution to the things they're worried about. We've got more to do, and we are currently realigning our quality patient safety resources, and within that we are going to really focus on making sure we get back to compliance of 30 days. So we'd like to get back to 70% of complaints being answered within 30 days. We will always have some that are more complex, but the important piece is negotiating the outcome with our patients and their families. And I'll pause there, Anne.
Thank you very much. Thank you very much for this very clear report, which gives us a good indication of improvements. It's good. Are there any questions to Jenny? Helen?
Thanks, Jen. Thanks, Jen. I just wondered, obviously the Civica has been very helpful. How far have we actually got in rolling it out across the health board?
So we've still got a way to go. We are just focusing on mental health at the moment. Right. So we've rolled it out to a number of acute areas and we're rolling out to mental health. We've still got, I think we're about 50% of the way through in terms of rollout.
Mental health?
No, of the health board.
Oh, right, okay. So,
and we obviously prioritise mental health to ensure that we were able to get the service user feedback from there as well. But it is tricky in terms of getting the responses completed. So not everybody wants to complete a survey. But you know, we are getting pleasing results when patients do that, and we're making it as easy as we can do for patients.
And sorry, just that's another question. It was to do with, obviously you've rolled out the PALS service. I just wondered, so what sort of experience have the PALS officers got? Because obviously they're now trying to deal with early resolution. Yeah, it's perhaps a step up from just being they're paid employers as well.
Yeah, so the PALS service, so they've only been live a couple of weeks, so they're still bedding in. So they are made up of some additional roles that we've appointed, and we have moved something called the patient liaison officers over from the reception team effectively to work with us. So those were put into place during COVID. So I think it's early days. A lot of the feedback they're getting is around communication, just the simplest communication with families, which I think if you don't deal with them early, they snowball. So there'll be more to come from PALS, and obviously bring that back through this report as and when they get more embedded in. But they're 2 weeks in. They've got bright orange T-shirts if you see them, so they're very visible. And you know, we're very excited that those have started in post.
So do they tend to be people who've already been working with a health board and have
It's a mix, actually. It's a mix. But we were, you know, Tanya is very patient-centred, as you know, and person-centred. And, you know, we deliberately wanted to recruit people who we knew could go out and have those early conversations and be confident about that.
Yeah,
and actually take some of the burden off the ward staff, because it's really difficult, isn't it, when you've got a busy ward, you're running here, there and everywhere, and actually having that time to stop, you know, actually isn't always possible in the way they want to do that. So this is about providing a resource that we can call on to say, actually, let's sit down with you and find out, you know, what's at the heart of this.
Yeah. Thanks very much.
Okay, thank you. Any further comments? No. Thank you. Can we move to the integrated performance report, please?
Thanks, Chair. So this is the Q2 INTP outcomes report. I just want to say something quickly about the report itself before going on to sort of the content of the report. Drawing out a few areas and then inviting questions. So colleagues will be familiar now with the structure that the report follows and using the life course framing. But hopefully you'll know we've got an intent to iterate the report through your own feedback, and we have an internal audit and we're following the management actions there. So in this quarter, some improvements we've tried to introduce are to be really clear on improvement actions where performance is deteriorating or not improving. Also be clear on where we are in terms of timeliness of data, make sure we're not making bold conclusions that when we're referring to older data was a theme of the internal audit. And also being clear in the chapter about what has been delivered and next steps. So we've tried to introduce some of these into Q2, but also you'll see when the Q3 report comes that we've got some more improvements planned this year before we sort of take a bit more of a whole look next year in line with the IMTP. So things we are working on, we are reviewing some of the metrics. For example, in light of some of the challenges in mental health, we're going to be more explicit about the mental health metrics, and similarly we're going to just check we've got the right sort of from a child check perspective. We've got 2 metrics included at the moment, but through the divisional reviews we identified that they're probably not the right, well, they're not the right ones, so we need to have a look at that and see how we switch or transition to the priority ones as sort of advised by the team and by Jen. We're also going to try to make sure now we've got the performance management framework we're enacting, that the actions, interventions identified in that space then flow in more directly from the divisional reviews into the report. And we're also seeking to sort of blend the 2 chapters of the clinical futures and ministerial priorities. And the last thing just to say on sort of structure of the report, we are now already, as we do the planning for next year, as well as doing the plan, we're thinking about what the monitoring of the plan looks like, which will pick up learning from the approach from this year and previous years, but also make sure in our plan our commitments are really clear on the actual deliverables, the milestones and the intended impact. So therefore the report will have those clear baselines upon which to comment. So that's just a bit about the structure of the report. And then I just want to draw out some of the positives before just drawing your attention to some of the challenged areas. So just wanted, in terms of delivery of key commitments in the IMTP, it's already been mentioned earlier in the meeting around the new endoscopy unit opening on the 6th of November, a real important development. Again, Tracy, who we met earlier, and her team being really critical in getting that commissioned in a record-breaking amount of time from handover of the building. We will expect to see, in line with the appointments they've made, some improvements in the endoscopy position, which is obviously critical for both our diagnostics performance and our cancer pathway performance. Similarly, we are very close to, so maybe we'll highlight that in Q3, but the breast unit being handed over in YYF and the Tredegar facility in phase 1 of that in December. The Bevan facility in Tredegar. We are in implementation phase of the cataracts business case that we've previously signed off. So again, in terms of impact on activity, the Neville Hall hub will be operational from January, and we've signed outsourcing arrangements now. So again, we'll see ramping up of activity. And we've already mentioned some other key sort of developments in terms of opening of ASA House was referred to earlier. In terms of some of the quantifiable improvements, we have made good progress with long waiting patients for planned care. There has been a real focus within divisions on doing this and eliminating over 156 weeks wait. We are close, but not yet there in terms of total elimination by the end of the calendar year, with a few with some sort of stubborn areas in ENT and spines that post divisional reviews and the team have been asked to review again, but there have been significant improvements, and that's essentially been on the back of just really rigorous sort of grip and oversight, real drive on treating in turn, as well as some pathway and alternative ways of doing things in terms of ENT using audiologists, GPs reviewing lists, and the back pain pathways. We've also seen this quarter improvements in some of our efficiency metrics. So our DNAs in outpatients, we compared to this time last year when they were 6.6%, they're at 5.6%. So again, that's really important that precious capacity is used effectively. And again, that's the outcome of some sort of focus management intervention. And we've also, I'm not quite sure if we're leading the way in Wales. I think we are still in PIFU, so patient-initiated follow-up, so alternative ways of managing follow-up outpatients and see on symptoms. There's a standard, a Welsh standard of 20%, which they'll admit is an ambition really, and most organisations are nowhere near that. But we've moved up from this time last quarter 11.7% up to 13.3%. So that's really important that we're not from an efficiency perspective in how we're using our resources. So just that there are other good stories within the report, but I just wanted to highlight those. In terms of the areas of challenge, it's already been mentioned a few times today, but the most significant areas are our urgent and emergency care system. It is important to note we have seen improvements. We've seen improvements in ambulance handovers. We have seen some improvements in wait to be seen, and even in the numbers of the delayed discharges, so the pathways of care. But I think we'd all admit we're not where we want to be. We're not where we'd like to be for our staff or for our patients. And this is a theme, as Nicola touched on earlier, that we picked up through the review process and in exec team. There are actions, as we talked about, whether they're linked to the winter plan, the safety flow initiatives and the patient safety events referred to, and as we've touched on today, an additional session with the board on the 12th of December. But that it is without a doubt a key area of focus, and we need to sort of supercharge those improvements to bring some additional and some more focus and resilience into the system. So that's the predominant really area of concern, despite some improvements. You'll see from the report other challenges. We have been typically very effective in the waits for diagnostics in terms of 8-week waits. The team have been trying to, from a radiology perspective, you'll see in the paper that has worsened over recent weeks, linked to some choices around the financial position. So post the divisional review, they'll be looking at how some of that can be, and what other choices to bring some of that worsening position back online, and what the options are to improve. And the last area of concern I just wanted to highlight was around mental health, which we've talked about here in previous meetings as well. So we did have a deep dive in our exec performance meeting around, particularly around adult mental health. We've got 3 challenges against Part 1A, Part 1B, and some of the areas we've got big staffing vacancies. At the time when we had the session, it was 56% absence in assessment staff, increase in referrals from an average of 1,200 a month to 1,500 a month. And also alongside that, a real lack of clarity around the rules of engagement. If you think around the planned care specialties, they're very rigorously regulated. I say regulated, the rules, you know, the RTT guidance, as we all know and love them, and that's quite very, very clear on what's appropriate and what's not appropriate in terms of waiting list management. And that just doesn't exist in mental health. So I think it's fair to say we've got some bad practice or unclear practice in terms of how to manage those lists. So there's work underway in all of those areas to support and address them, and looking at pathways as well. So the team are pull together options around times of assessment. We've done some benchmarking, so there's opportunities to increase capacity there. Looking at virtual solutions to providing assessments, and much stronger approach whilst the guidance is being resolved around gatekeeping and screening of referrals, recognising that just because somebody's been referred for A, it may be that through a triage they can be redirected to a more appropriate service. So that is a real area of concern, but just to give the board assurance that the exec team, this is very much on their radar alongside the 30, 60, 90-day plan. And we will, in the future reports, make sure we give a bit more prominence to the correct metrics to make sure we're focused on the areas we want to improve. So I'll pause there and happy to take questions on the areas I've outlined or any other parts of the report.
Thank you, Hannah. Thank you. Are there any questions or comments?
Yeah, just one briefly, and it's just on the ambulance handovers, just because I've noticed several board papers have brought it up, and whether or not we need to look at it in the wider context of what the system is for people attending kind of A&E. So I know that we have discussed this before, but I was just wondering when we were likely to get a bit more of an update on it, that's all.
And you're looking at me to...
I think we can probably pick it up at the briefing that we'll do in December, because I think it's interrelated to how the whole UEC system works, and therefore the work we're doing in involves, because it can't, you're quite right, you can't see ambulance handovers in isolation. They are part of a system pressure. And whether you look at that pre-arrival or whether you look at that post-arrival, there is something about how we manage that slightly differently, which we're picking up in many of the 6 goals work streams. I think it's important that we brief the board on, you know, what those work streams are and how we're going to test the effectiveness.
Thanks. I sort of assumed that it would probably be in that, but I just wanted clarification, so thank you.
And just so what we're going to try and develop is a kind of unscheduled care dashboard that we can share as regular information for the board, trying to put the whole system or the big metrics in one place, which, you know, we've got information everywhere, but so trying to really get underneath the position. So it's something that I know the information team are looking at. So I think, what do we need as a board and executive team together? And I think what we have seen, so if you look at the general trend line, and you know, we talked about the safety flow program, we have seen improvements in handover, lost hours, handover rates. The beginning of September, aligned to the patient safety event in the Gwent, we had the best 2 weeks I've seen on handover lost hours. We were losing before May on average 700-800 hours a week. We lost 300 hours in those 2 weeks. And trying to understand what was different about those weeks, and then, but our ability to maintain it is not there. So the last 2 weeks have been really, really challenging, with 10-hour waits appealing back in the frame again. And the basic data does give you the insight, and the acuity is often what's presented as the challenge as well. We've seen the number of patients waiting more than 24 hours in ED come down. So there are snippets of good news in there, but our system's not resilient. and trying to understand that. So I think we can try and get that dashboard together for that session and share with you so you can see kind of those hotspot areas and trends and hopefully some of the correlation.
I had a question on the integrated dashboard that we have separately. It's just around the hospital-acquired infections and around the, and I know that performance isn't good on that, and we're not really seeing the improvements we like. And I know that there's an awful lot of work going on around that, but I wondered whether or not, I don't know at patient safety if there's been sort of like a deep dive to understand what the challenges are. If there has been, that's fine, but I just wondered whether or not that was, I know it's one thing that is very much playing on the mind of why it's there, but I know there's such a lot going on. Yes, understanding the challenges. I know that it's a focus on the Welsh Government in terms of their reporting, what have you. Do you want me to pick that?
Yes, please.
Yes, so we have presented a deep dive to the Patient Safety Quality Outcome Committee. We've also presented that to the exec committee. I think it's fair to say that the complexity of some of our patients means that it's incredibly difficult to tackle single cause. So there are multiple root causes to this. Some of it is around the complexity of the patient. There are clearly issues around antimicrobial prescribing, and we've commissioned a sort of refresh of the antimicrobial prescribing group. And we've also started to look at things like gram-negative, gram-positive, which James will very articulately explain in better detail, but really is about how we look for, the community acquired versus hospital acquired, and how we understand the prevalence. So there's a big piece of work that's being done. We've got to do further work in those areas, and we are planning to bring another deep dive back to PQSSC, but just to say it's an all Wales picture.
Oh yeah.
And I suspect if we looked across the border, it would be an England picture as well. And I think it's about this level of complexity and comorbidities. There is definitely work we need to do, particularly around some of the fundamentals of IPC. But we know that, Moy is leading that work, and we're continuing to refresh it and refocus.
And Public Health Wales is now giving an overview of the All Wales picture by type of infection, which could be very helpful to us.
Yeah, absolutely.
Really, to inform it. And they're doing further work, and I'm sure will be helpful. But
Yeah, it's just a quick thank you for including these improvement actions in there and linking them into the indicators we've got. We're doing a hell of a lot of work, but linking them all together like that gives us a little bit more flavour, a little bit of assurance that things going on behind these indicators.
Thanks, you. And there is still more to do in terms of like timescales on those, and also, but having them explicitly is, well, are they the right actions? One, have we captured everything? We picked up a bit of that, but are they actually having the impact? And if not, let's stop.
As you say, there's an iterative, there is an iterative process that will go on for, it won't be next, it'll be, several of these down the line, but I think it's a good step.
Thank you. Anything further? Okay, thank you very much. Now we go on to the finance performance.
So the finance performance report for the meeting today is based on the month 7 period, or 7th period, sorry, to the end of October 23. So if I do the overview of the dashboard, so it presents a year-to-date deficit of £41.8 million for revenue and a forecast deficit for revenue of £57 million. I'll expand on that in a moment. Capital's online to balance financially, and we're spending a proportionate amount of our capital plan for the year to date, which is quite unusual and quite positive. In terms of the month 7 figures, it does reflect the new Welsh Government funding that we've received of £89 million. And that, in round million figures, that does take us from the month 6 forecast of £145 million deficit, the £57 million deficit we're reporting now. In terms of the impact on the year to date, that change in the proportion of funding we've built in
shown an improvement of 52 million. In terms of the board, I think it's worth noting that our run rate, if we hadn't had the money, continued to be at the lower rate for month 7 as it was for month 6 than the previous 5 months. So we're running at about 10 to 11 million pound per month as a deficit. So that's a little bit lost in the numbers, but because of the new funding that's coming in. So that's positive, but we still need to go further, and I'll come on to that in a moment. So in terms of the forecast, the position, when you factor in the new funding, does align with what we forecast as part of the mid-year review and the very detailed discussion we had at the board before we posted that deficit previously. The thing to note around the Welsh Government funding we have, there are expectations on the organisation. And those expectations are that the Health Board, on the back of this funding, will achieve a control total or an outcome of a year-end deficit of £13 million. And I know this has gone out in the brief I've issued, but the Welsh Government assessment of how we get there includes the fact that we had an IMTP plan of £112 million deficit, an expectation of us to take 10% off that through additional savings. And then with this new funding, it will leave us with a 30 million gap as a deficit that Welsh Government has allocated us as a control total. So it did not take into account our revised mid-year review month 6 forecast deficit. As a result of that, we're currently £44 million off the control total that Welsh Government are looking for us to achieve. We did have at the mid-year point, and we continue to hold a risk range of plus and minus £5 million. And obviously the challenge from Welsh Government is to continue to deliver more savings and improve on our gap from the control total. And in terms of us as a health board, we constantly need to make sure we're delivering the savings we've identified, and obviously continue to look for more for next year, which is obviously where the IMTP plan and next year's plan comes in terms of some of the opportunities that we can deliver through that. So it's very important to be aware that we are, as a result of the new money, we're not as far away from financial balance as we were, by £8-9 million, but we are still a distance away from the control total the Welsh Government wants us to achieve. And I know we're going to pick up more of that in the in-committee section. In terms of key points to note for the year-to-date position, and our income continues to assume that we will receive all our anticipated funding that we are importing to Welsh Government, including all pay awards being funded. For month 7, we saw an increase in pay costs by £4 million, but that was predominantly due to a funded medical pay award and a backdated pay award. The positive news is our variable pay cost reductions is continuing to hold, and we've seen reductions in off-contract agency usage, reductions in enhanced care usage, and our run rate for variable pay is continuing to operate at £1 million a month less than last year. So a positive picture on the actions taken on the variable pay. In terms of non-pay, that increased by approximately £4 million a month. Again, some funded items in there. Key points driving in-month deficit was around some high-cost drugs and a lower level of dental contract clawback than expected. But there are mitigations in place so that they can be managed within the year-end forecast. In terms of savings, again, a positive position on that. We had a £51 million savings plan as part of our IMTP. We're reporting a forecast delivery of that at 42 million. So we are £9 million off our total target. 42 million, if we ultimately achieve it, will be the highest savings this organisation has ever achieved. At the moment, £35 million of that is being recorded as green, so expected to be delivered, the balance amber. And £80 million is reported as year-to-date actual delivery. We've touched on elective care performance and diagnostic performance in the performance report, so I won't go into that too much. Systems pressures we've talked about already, and the level of delayed transfers of care and the costs they are driving for the system. So that the detail of that is in the report, and we've discussed it earlier, so I won't repeat again. In terms of our public sector payment policy, we've achieved our 95% target, and we're within, at the end of the month, our cash holding best practice levels as well. And just to note that we will be, or we have actually sent a letter in to request strategic cash support as part of our deficit, which needs to go in before tomorrow. So in the round, I think the big news is financially we're in a better place because the Welsh Government, we've still got further to go to get towards their control totally allocated for us, and obviously to look at opportunities and continue to go on opportunities for next recurrent. Thanks, Sam.
Thank you, Rob. Are there any questions or comments? Paul?
I mean, that's incredibly helpful. I suppose really it's the time frame for next stage, next phase, which will be not only this year, but the following year after, etc. So I wonder, I'll mention the word radical again, as to what radical plans are there likely to be before us, so that we can actually address these ongoing problems of funding, because I think that's probably sort of the expectation is that we will be putting forward plans that we need to be able to live within those means, really, because it may get tougher as time progresses.
Yeah, so in terms of the more radical aspects, obviously our annual plan, our MTP process will draw out some of those. I think the issue for us really is to look at a multitude of things which we continue to do. So in terms of can we be more efficient? So part of our benchmarking exercises, for example, identify around about £17 million if we were operating in comparison with relative high performance peer group benchmarks. That doesn't fully bridge the gap. So you're right, we need to look at more radical and system level options around that. We're looking at bed capacity and our bed levels. We're obviously off the clinical futures plan as intended. Some of it due to surge and operational pressures. Well, actually all of it due to operational pressures. Some of them due to delayed transfers of care and the surge requirements on us. Obviously, our bed base is something we're looking at in terms of savings for the part year this year, which I mentioned earlier. The full year effect of that, if we can achieve them, will certainly help us. And depending on what other supporting alternative services we need to put in to enable those bed savings, we should be looking at quite some significant savings there of the order of, I would suggest, £7-8 million if we can get there. Okay. The wider piece then around reconfiguration, like I've said before, I think there's a reality that we need to consider around how thinly we spread our services and where we provide services before we look at what we provide or don't provide. And I think that's a big challenge for us now in terms of understanding what our plan is, what it means in terms of some of our estate and where services are delivered from. So that doesn't actually give you the answer specifically you're looking for. That's obviously our challenge going forward now as part of the rethink on our strategy.
Can I ask Nicola, have we got a time frame for sort of options and proposals?
Well, I think, as Rob said, a lot of the work that's already underway this year, I'm hoping will have a much greater impact on our next year plan. If you look at the variable pay reductions that are in the report, and we met with Welsh Government yesterday, and I think acknowledged, we potentially taking, nurse and healthcare support worker agency down by 13 million this year, despite some of the hotspots where it's increasing. You take that into next year as a full year effect. The reduction in flexi rewards, which is coming through, which is £500,000 month saving, we'll have
half a year of savings this year. That's another 3 million next year. That's just on kind of basic pay. We've saved, you know, the enhanced care. We've seen reductions there coming through, and there's further work to pilot that. The reconfiguration, as Rob said, you know, the discharge work, if we can get our capacity out, then that's a key plan going into next year. There were things that we, you know, things like the MIU, we identified some of the areas in the equality impact work, which we can't release quickly because there's contractual issues to sort, so we can start chasing some of those down. So there's, I think we do need to probably, you know, I'm looking by the end of January to show that line of sight going into next year. We, you know, the St. Willows we've talked about in terms of the broader estate plan. So there's a number of things that I think are a problem for us in delivering this year, but are progressing to a stage where I'm hoping next year we'll see some greater traction on, and we need to keep that pace up. The value sustainability structure that we've now got in place with a fortnightly beat, I think really is helping us, you know, the work we're doing on CHC, medicines management. I think we've got grip back in some of those now. And it's interesting, the whole clinical effectiveness debate that we've had as a board as well, in terms of the evidence base, and James involved in this work at the national level, is I've been linking as part of the National Value and Sustainability Board, is what work Welsh Government are doing to help us with that clinical effectiveness debate, and what things is there evidence to suggest we might not be doing, and can we take a national approach to that rather than individual health boards trying to do their own thing and then we end up with inequity. So that's a piece of work that Sally Lewis, who used to work for us, is taking a key role in. So I think with the national work alongside what we are doing locally, but I'd like to think on a timeline that by the end of January we you know, we can set that out. And we had a useful meeting with Welsh Government yesterday. It was our meeting on the finance. They've met with every health board to see, you know, where you are against the control total and what your issues are. I think there was good recognition of the progress we've made around some of these areas, you know, and some of the savings, albeit it's not really helping us on the bottom line sufficiently. But I think what, you know, the challenge back is what would it take to go further? So we've agreed to set that out, and we, you know, and we've shared that apart from chasing the issues we've already set out, you know, our big opportunity is planned care, but we're talking a couple of million. You know, it's not going to bridge that gap. But they were quite keen then to see that opportunities pipeline, what I just described in terms of going into next year. What is that kind of strategic direction we go in? So we're going to do some work on the back of that, and again, would be helpful to share that with the board, probably in the December session we've got as well. I think because we've got an IMTP session on the 20th, and we pull some of this together in a bit more structure for you for that session as well.
Can we note that our huge thanks to Nicola, Rob and the team for all the hard work in getting this together, and because I think it has been a huge challenge. Obviously there's more to be done in order to future-proof the sort of the responsibilities really. Thank you.
Ewan?
Yes, so just to be clear then, the discussions you've had, there's still the expectation of us finding 44 million by the end of the year.
At this point in time, that continues to be the ask from Welsh Government officials.
Okay, but we have nothing in front of us at the moment that shows us that timeline or that line of sight to that figure.
I've made it clear that at this stage there is a discussion on planned care to have with Welsh Government, because I want their support in us doing that, because I know from some conversations, you know, we will build a problem for next year and the ministerial priorities. So I think there is a conversation to be had on that. But I think to take, you know, for us to take 40 million, you know, 44 million out, we will impact patient safety in this organisation, which we have not got a line of sight that enables us to do them. That's not to say that we're not still looking and we're going further and we're doing all the things we can, but you know, I can't see a line of sight that does that without us accepting a patient safety risk.
Okay, so when you come back in December, you'll give us a line of sight to what figure we have to back you on.
Yeah.
Basically.
Yeah.
What that saving is going to be between now and the end.
And the risks. We've got to have clarity.
No, because as Rob mentioned earlier around the beds, so we've been, you know, we've had a conversation, we try to be bold on the beds. Let's, you know, it's not great spreading your workforce thin, we just fill in with capacity, so let's take the beds out, you know, and it helps us address the financial challenge. When you face like a weekend we had last weekend, when we're gonna have to open beds. If we've got nowhere to put people and you've got people queuing at the door, we can't make the changes as quickly as we can. Are we prepared to allow people to wait 24 hours in an ambulance and people not get a community response? You know, because of the money. You know, that's the challenge we are facing. You know, and it's huge. We know there are better ways we can, whether you can enact the change in the speed that we need to. So we have been really clear about the risk of the bed capacity solutions. And, you know, and you can sometimes, you can get a different response when you get the right people involved. And it's an escalation process. You know, so we've been holding our line on the capacity we've already taken, because we have taken, you know, half a ward out already, or a bit more with a stroke. We won't be far off 30 beds. And that's why some of the data intelligence is to understand, is that impacting on the pressures at the front, or is it about processing issues and so on? But it's that bit going into the winter is going to be a huge balance for us around, you know, we got some bold assumptions in our financial plan about the winter, which, you know, does worry me. Yeah.
Yeah, I just ask a question that maybe to Hannah. Are we still on track to take the beds, the wards out of St. Willis this year?
So we are working with Jen's team, colleagues in the patient safety event to test what that would mean. We have been successful so far in reducing beds, but there are pressures. There's another event coming up, but I do think we'll need to, as Nicola said, just assess that in line with pressures. In terms of a proposal around then, what do we do with the beds at St. Willis? That will come back to the board. We've got an exec team conversation at the end of November on that. But the focus primarily, I'm sure Jen will come in here, is to make sure that those who don't need to be in any bed, whether it's beds in St. Willis or otherwise, are expedited to the most appropriate place. Jen, do you want to come in on that point?
I think you've said it perfectly, Hannah. The focus is on making sure that people who should be at home are at home, and where that provides an opportunity, that we take that opportunity to relook at whether those beds are needed in the system. And I think that's the process we're working through at the moment.
Just to give some context to that, out of the ward that I looked at 2 weeks ago, there were 28 beds, 28 patients, 6 were medically unfit. The other 22 were waiting for placement.
I think I understand that, but we are obviously in where we are. So I think, and I know it's difficult, but you know, if you've got that 20 beds, let's say, that you don't need, then I think that we need to see that they are being taken out.
Absolutely.
Although the difficulty is before we you hang on to them for a bit just in case, and then filled again, you know. So I think you've got to be fairly vigorous, haven't we, about
and you can deal with peaks. So somebody just describe. So we've taken half a ward out of the Gwents and we've got some extra beds, and we were at a position on Monday morning where we already were boarding 2 patients on each ward, the Grange. So that's 2 people in areas that are not supposed to be, you know, asking us to open day rooms, to put people in day rooms. And if you go to Yab and it's got a bit of a red line on it, it's like putting someone in a goldfish bowl. So completely unacceptable. And you know, and you think, well, if this is what we're going to do, you just want to open a ward back, even though there's a different staffing. You cannot, you know, which is why I think Andy's point, what you want to do is don't spend your teams creating a ward out of a day room. Let's get them to look at how we can enact the discharge, working with the teams. That's the right thing to do. But it's just about our capacity, our ability to influence with partners and get the pace we need on it, given the time we've dealing. So, and we almost said when we close the wards, we're going to lock them up, them up. But then when you're faced with that situation, you've got to get the key. Do you know what I mean? Because you can't carry on like this.
And obviously, you don't, the events aren't taking out 24 beds at a time. You take out 6, which means part of the ward is still running, which means that, there's a greater temptation to, when you're under that much pressure, to balance the risk.
I just come in. The important thing as well is, and follow on Jen's point actually quite nicely, is we need to take batches of beds out to release costs. So because we can close beds and not save any money. So we just need to be aware of the extent and the steps that actually release cash.
Yes, I think that on the issue as well of St. Willis and any move from there, we have got to be bold in any discussion on reutilisation and really, really improve the facility for individuals where they might be in less accommodating accommodation than they are. I would hope. David, sorry.
I was just going to add in terms of, you know, I know I'm being quite emotive about it because but when I was reading a Twitter feed this week about an A&E consultant leaving a hospital in England who said, you know, I felt like I'd had a good shift because I got to see all my patients, but I left with 18 people in the corridor. And that's almost become the norm and the standard of care. So it's just reinforced, this is a systematic challenge. You know, I just want to make sure our health board provides the best possible. But it was when you read it, you know, our whole issue around ambulances and corridor care and boarding patients, and, you know, we don't want to be doing that. We want people to be in the right environment, but it is just to reinforce we're not on our own with this challenge. No. This is the systematic challenge, but, you know, we need to do what we can do.
Gavin?
I'm sorry to be this one, but in the risk section, there's a couple of items in there that are digital and technology risks, in particular in relation to the national programmes around Link, RISP and WICIS. I'm not saying I need an answer now, but maybe this is something for the Finance and Audit Committee, but particularly the WICIS risk in relation to the long-term plan for WICIS and the impact on our revenue. Could we get an update at Finance and Audit Committee in a couple of weeks' time?
Yes.
Yeah, do that.
And we note the other risks, which also we need to address.
Yes.
So that needs to be included. Are there any further questions? I note that there are a number of capital schemes that are going to come into effect shortly. I think it'd be really, because most of these were designed and approved long before most of us got here. I think it's really important that we need to understand the financial and staffing consequences of these proposed openings, because we don't want to get another nasty shock about whether it costs more and whether it's been accommodated and where we're going to get the staff from if that is the case. I just think the board needs to understand the magnitude of any demands on their budgets. The future. Okay, well, it's a somber report, but we've known that. But we and you have been doing this. You have been grasping this nettle, but we have to go a bit further, don't we? Really, and I don't like the fact that the additional money is conditional, because the conditionality is somewhat unclear.
Have actually received, except for the 9 million for energy, which we had it very quickly after the letter, which I was quite surprised at. So I think
what we've received can be taken away.
Well, that's what I was about to say. Is I think for this year, I think it's soon at this point that we can retain it. Next year, it's a different matter.
I think just it was interesting out on the Welsh Government call is some of the reflections is the amount of work we have done and we are doing. Yeah, probably is greater than others. Yeah, it's not presenting in our position. And I think, you know, we tried to set out a bit more about the context around, you know, where we were pre-COVID, leading up to the Grange Transitional Fund and what our new systems cost us, you know, how we were impacted, and a lot of that underlying position that we carry in. So, but I think it was recognised the amount of work we are doing.
Yeah, good.
Even though all the numbers are not, that's the results that I needed to.
But I'm glad that they have acknowledged that.
I didn't think it was acknowledged, did you? And I know Hannah.
Yeah, I was.
Yeah,
I think it's a positive reflection back, other than the ultimate challenge. So how do we?
So what are you going
what
to
do
do?
Yes.
Well, yeah. Well, that's the question posed to the whole group. Thank you. The strategic risk was 4.6.
Shall I pick up the other item on finance, or are you happy to?
Oh, all right. Oh yeah.
So Nicola asked that we put together just a summary review of the governance that we put in place for financial recovery. So we put together all of our sort of like financial governance just for completeness. including our overall regulatory framework, our IMTP and our recovery approach identified in that plan, which we are effectively living now. The budget setting approach to engage budget holders more for ownership. Some of the structural things we put in place over and above the norm, like the Value and Sustainability Board and the actions linked to that, but also the additional board briefings we put in place, which we have here as well. The new performance framework is quite a critical step in terms of our change to financial recovery. Hannah mentioned around the escalation process that was implemented recently with the divisions and action plans in the region there. The clinical advisory forum and the benefits of having a multidisciplinary impact assessment, clinically biased on that as well. Financial control and actions, and a lot of these are reflected in the reports we've previously provided. And then the all of our mechanisms have been considered against some Welsh Government good practice frameworks. They're the two, I call them daisy pictures in the appendix. And we concluded we've designed an effective framework that covers off those daisy elements. Although the challenge that we're not living within our budgets does exist. So that's paper for today.
Thank you very much. Has anybody any comments on the framework?
Yeah, just the one, obviously the proof of the pudding is in when we get to the it all. You may think we've designed one, but obviously we are not living within our means at the moment. And all of these controls, okay, they need to mature, but some have been there for a while and not bearing fruit at the moment. I'd say there's a very marginal change in the run rate, but it's to be seen, I think, whether or not this is an effective. I think that's a fair conclusion. Our savings levels are greater than elsewhere, but we are, as you say, not living our allocations as it stands.
Yeah, I think that the board will require some objective evidence that the accountability system that's explained in this and through the divisions is starting to really be effective. Because it's a change in the culture. Thank you. So we're content with that for the moment, and obviously we'll revisit this as we move into the discussions on next year. Strategic risk report.
Yeah, thank you. So this is a continued further development of the risk report from that Rani has been working really hard with the team and follows our board sessions in terms of reframing the risk register. So we've got that 8 high-level strategic risks with the 18 sub-risks, and they've now got 14 of those have already been reviewed by the relevant committee, with 4 of the sub-risks which are due to go to finance performance in December. So issue. Each of those risks have got the objective, the causal risks, impact, risk appetite, and where we are against the level of assurance. You know, I particularly found helpful the kind of appendix which shows your risk appetite and where we are against it. I think picking up Sherry's point earlier about understanding our risk appetite on these and where we are. So concentrating on those ones where the risk is higher than our appetite is really important. So you know, I find it quite a helpful framework. So welcome kind of any comments on that, but hopefully through the committees they've all been signed off. As I think Chair made reference earlier, there's a new risk that has been proposed from the Population Planning Committee around the kind of health protection issue, particularly around COVID vaccinations. So looking for approval to include that now on the risk report, but you know, note the ongoing work to continue to implement and embed risk management. And as I mentioned earlier, I think some of our reflections is health and safety. Once we've done that, the work needs to be brought into this risk report more explicitly. I'm happy to take any comments or questions, which I'm sure Rani will answer better than me. Thank you. Are there any comments or questions?
Just I like the whole format of particularly on the committee bit responsibility as well. So I think it looks and is much more joined up.
Yeah.
And I think it's helpful to us all to be able to look at strategically where all the risks are and there's ownership of them. So thank you for production and explanation, Rani. Thank you.
Thank you.
Thank you. Thank you, Rani. Okay, we move on. The Executive Committee Chair's report, then Nicola, please.
Yeah, thank you. So standard report setting out some of what the executive team have been up to over the last 2 months. Just to pull out a couple of areas, particularly under the quality safety theme, we, in both the mental health and maternity, taken some work that's been done on national levels, just to test in terms of our own assessments of where we are against those recommendations. So that was really helpful, and these influences where we're at, knowing the 1 or 2 areas where we need to do further work. It's worth just pulling out, it's in the challenging times, we talked about the quality report earlier about the reverse mentorship programme and staff diversity, making progress in those areas in a pragmatic way, identifying leads and setting up networks is really important for us. There's quite a lot of digital, you can see within there, we had quite a really good session on the national data resource. Paul has brought to us, and it was quite a interesting session. We didn't get the end of the slides because there was so much anything with the other, I think, but really seeing how that can improve our intelligence. The hospital, the EPMA side of things, Information Governance Subcommittee report put in, which I think is really good to feed up into the broader committee, and also progress on the nursing care record. So quite a focus on digital, and Paul's got a long list of things that he's trying to, but I think it's really showing the benefit of having that kind of dedicated focus on digital around the executive team. And then our senior leadership, system leadership group that we can continue to evolve, which is ourselves with many of the senior leaders in the organisation. It's been dominated very much by the financial challenge over the last few months, but we are really trying to change the focus and put a bit more around the prevention, innovation, those type of, and we had a useful session on diabetes with cardiovascular coming up as well, because they generally touch all parts of the system in some shape. And Tracy's going to be refreshing the programmes of work around those 2 particular disease areas. So I'd leave it at that. Thanks, Chair.
Thanks very much. It was a really helpful report. Are there any questions? Huge amount of work being done, and I'm glad that you're finding some time amidst the pressures to concentrate on the future as well, and improvement. That's really important. So thank you. The Public Service Board update then, Tracy.
Just a brief update really. Most of the background you'll already all be aware of because you've been part of it. So we adopted the Marmot Region approach now just over a year ago, and that has sort of guided a lot of the work that's been going on in the PSB space. The landscape has become a little bit complicated in terms of, whilst the Marmot work was being done, which was a deep dive into our place and understanding our place to understand the recommendations, the health and wellbeing plan was also being developed. Both plans were almost simultaneously adopted. So you almost ended up with 2 sort of policy positions within the PSB. However, that's worked through. There's been a chief execs group that's been formed with Nicola, and the chief execs of the 5 local authorities, the chief constable and the chief of fire, have met a few times, and that's really helped give a little bit more focus in terms of taking that broad strategic view, but also focused it down on what's achievable and what is deliverable. And that sort of guided the conversation then into a workshop that was held on the 31st of October, which Pippa also attended, where we started to look at the recommendations from the Marmot report. There's 192 recommendations in there, and how we theme those into delivery. On the rise of that meeting, which was very useful because we had community groups there as well, which started to challenge us in terms of how strategy is set and how it is delivered on the ground, and how that doesn't always meet. So that was a useful challenge to have. But on the rise of that workshop, the PSB formed an extraordinary meeting
that was to discuss the future direction and how we were going to set that strategic pathway. And where we got to, because of this complicated policy landscape that we found ourselves in, we agreed that the Marmot report, which is very evidence-based and data-driven, would become our why. It would describe what we needed to do in Gwent. The Health and Wellbeing Assessment Plan is very much a descriptive document. So that gives us our what. And then a group has been formed, a group of officers has now been formed, and they've been set the challenge of describing the how. So they're going to write the action plan by combining the what that's in the Health and Wellbeing Plan with what's in the Marmot report. So hopefully we will have a coherent process in place. So that is being done. That's going to come back to the next PSB meeting as a draft. And then hopefully what we will have is a really clear set of strategic options. We have agreed on key things, which is mirroring the conversations we're having here in terms of focusing on children and young people, understanding the wider determinants of what creates harm in our communities, and also looking at how we can build prevention right across the pathway. So very similar conversations to what we're having here. Not that we're influencing the PSB in any way, you'd understand, but we're trying to make sure that that narrative is very, very coherent and aligned. So it feels incredibly positive, and what there is in that space, and what has continued to emerge over the last few months really, is a will to get this right, a will to make a change for our communities, but more importantly, a will to do it with our communities and understand how we improve services and information in the context of the way people live their lives. So it feels like it's got to a really positive space. So a lot of workshop discussions, and it was replicated in the conversations we had at the RPB event in terms of how we rationalise that relationship between PSB and RPB, which I suppose is the next job across that strategic partnership.
Thank you, Tracy. Very helpful. Any comments? No? The RPB then.
All of that. So the paper's there for information, just some of the areas we've touched on already. Just to note that the partnerships, Planning, Population Health and Partnerships Committee had separate updates, those are summarised in this report. So a separate paper on the governance review that was undertaken, and a separate paper on the partnership capital strategy and plan that was referred to earlier as well. So this paper just sort of summarises progress there. In terms of the governance review, as we've touched on, task and finish group set up, but alongside that, as well as sorting out some governance, we had the exercise that Tracy's just referred to in terms of trying to be really clear on, okay, so what are we about and what are our priorities? I think there was some progress, but I think the potential for confusion, or not sure what the right word is, but the need to align the work that the PSB is doing in this space, the work that the RPB, and then obviously, as I talked about under the strategy item, how we fit into that is really key, isn't it? So because I think we might have started going into PSB space in the RPB conversation at times. Just the other bits to note with the governance review and capital, there's Q2 reporting due for Welsh Government. We've been piloting the tool that will come back through the RPB arrangements through the leadership group. And also there's some very active work at the moment about looking at what's a proportionate but appropriate methodology on the evaluation of investment, recognising my understanding, unless something's happened recently, is we're still not quite clear on the tapering, if there's any changes to that.
No, we haven't heard, and I think there is widespread support from the other RPB chairs now that we write to the Minister asking that tapering should be deferred yet again for another year.
Yeah. And then lastly, just to note that at the end of October, there was a letter received. I think that letter came to you, Nicola, didn't it, rather than to the RPB, but confirming recurrent funding around the Further Faster agenda, but asking that the proposals in that space be signed off through ISPBs, so the integrated service partnership boards, so the borough-based boards that sit underneath the RPB, and then ultimately by the RPB. So that work to look at against the criteria, look at what the plans to use that money, and the proposals come to the RPB on the 28th, 29th, the next RPB, with some clear asks going out into the ISPBs. We internally as a health board and Jenny can speak more to this, we have a view in line with the guidance and the aims of the policy around where this could add maximum value, and we'll feed that into the ISP.
Yes, the further faster letter came to the Health Board Chief Executive's copy to the RPB chair, which would give an indication that it's our Health Board HP money business. And yes, and the other issue was that it's very specific on what we should spend the money on, which is unusual. But it all seems to be replicating money we've already had. They're going on about AHPs again, and yet we've had extra money for AHPs. And you know, has this money been given out already, or it's just very, very confused as a letter.
Yeah, we have got a clear view though, Jenny. We do our priority.
We do, particularly in the priority space, and then a little bit around the end of life space as well. I think there's some opportunities to think about, you know, with the 6 goals programme, and hear a bit more about that. Seeing the board briefing around how we could match the money to some of the priorities we have within that programme.
Yeah, but it's non-recurring, isn't it?
No, there's a recurring.
There is a recurring element.
Yeah.
11 million across Wales.
Yeah. 11.95.
We've got 1.3, I think.
Yeah, across Wales it's 11 point.
Yeah.
And our but yeah, definitely it was there's a recurrent thing.
It'd be helpful to find out on what basis of resource allocation the allocations were made.
I don't think the letter was clear on that.
Oh, it wasn't clear on that. Okay, thank you. Any questions? No? Thank you. Joint committee activity.
Yes, this was the previous meeting. There was another one held yesterday. So the report is there for information. I was just going to draw attention to one or two things. So one, I just think it'd be useful for us to have a session in the new year around the genomics agenda and the precision medicine, because I think this sits very much in that kind of specialist space. I think we, as a board, really are cited on it, and we had a bit more of an in-depth presentation on it at the chief executives this last month, the month before. And it really is quite significant around, you know, genetic testing and looking at, you know, the results. But there's massive constraints around pathology, but there's massive expectations and opportunity around it. And I think us understanding that and what it could mean to our population, but also our resource, you know, utilisation in the future is significant. So I think it'd be really useful for us to get a session. Obviously, Cardiff are heavily involved, leading some of the EOLA's medical genomics service, but it's got a huge issue for us in terms of from a population perspective. So I think it's something we'll schedule in into the new year. Yeah. The other one just to pull out is the single, there's work going on to look at a single commissioner for mental health services. So it's very much at the development stage. We had some concerns as a health board by our service team about this, just to make sure in terms of the commissioner role versus getting into operational issues. So we need to be actively involved in this work. But there was some initial kind of evaluation of data yesterday at the committee on this, but really looking at eating disorders, CAMS services, secure services for mental health, and looking as well at opportunities of Welsh facilities. For me, my biggest point into this, and it goes back to your point about the ASA house, you know, the impact of doing much more upstream and avoiding, you know, escalating to need this type is, I think, is not enough focus on that. I still think there's a lot of variation across Wales, and when you do have which we've some of them seen before, how impactful some of the patients, you know, service user stories are on these. So I emphasise the need for us to look into that rather than just looking at how we do things now and providing it in a different, maybe in a local way. But a real good piece of work, I think, that we need to make sure we actively do.
Jenny?
On the agenda, it's going to pick up on the appendix about the sexual referral centre.
Yeah, I was just going to mention that.
Right, it's not about the additional funding, and I wonder if that been factored into any.
Yes,
we haven't may not received the request, but it's down the.
Ronnie and I were looking to see whether they needed to come through the board or whether they can go through our executive. So there was already phase 1 funding, but there's phase 2 funding now being agreed, which I think is in our financial plan. We just needed to check the governance on that and what our share of that to see what process needed to come through for that. So we follow that. But where it was being done almost in a regional level, now it's now gone through exactly this structure where it can be kind of more commissioned in a more kind of holistic way. So it's kind of going through that mechanism. But yeah, it's like something I need to do. I need to just do a check on whether the board needs to be kind of out for. I just want to just add one thing, sorry, because I know we've raised paediatric surgery with the community around risk and some of our concerns. So they want some outsourcing, and there's a decision to, it's in the risk plan, so it's not a new cost, but Cardiff will come up with opportunity, the backlog, and as long as we all support the that, we don't know nobody making it. But you know, between the outsourcing and Cardiff, we will get recognising there's a more sustainable piece of work going on, and looking at terms of what we've done locally, what needs to be done in Cardiff, what should be done in an English sector and all of that. So there's a wider, there was a workshop I know Hannah you went to first, which was looking at specialist paediatrics per se, but on paediatric surgery, which I know has been a kind of discussed, there is a plan to get to 52 weeks time. Let's get Hannah then, please. What is the norm for waiting in the units that you've looked at in England for paediatric surgery? Well, that information wasn't shared. Why not in the workshop? What was the point of discussing a quality service? I think the sort of purpose of the workshop was really more of a briefing and advance of the joint committee this week. So it was really trying to just describe what the actions and the short-term actions they're taking. But in terms of the ICP, Integrated Commission Plan for next year, there's recognition there's much more sort of things that needed, both in terms of pathways and opportunities to do things sort of very differently, not just children's hospital, but information on which works with shared. The outsourcing is looking at Nuffield and some NHS even share and that. Start as well in a financial context. So the commission plan was shared yesterday. You know, my reflections were, you know, they're doing a huge amount of work and it was great work, but it was quite traditional. Again, was assuming that there's going to need to be about a 3.5% uplift in funding. This is 140 million of our 1.6 that generally, you know, assumes more than the rest of our services. So I did reinforce, you know, the decisions we're having to take, the effectiveness of these, and how we need to be. I think we've got to be a bit more challenging around some of the services in our portfolio, and we might need to make sure we've got a more transparent discussion on it, so I can get into the scheme. It is difficult, you know. I did a lot of work with some of these services when I was in Cardiff, and they pay high profile, often high cost, lower volume, but they are consuming resources at a time when we've got huge challenges. So it was just something to reflect on. I know we've got the management that we go into more detail, but the outlook was not a different picture to what we used to. I see we don't run a challenge, isn't it? And we wouldn't have to nothing, but extraordinary. Okay, thank you. The key matters from committees of the board. Oh, sorry, oh gosh, I forgot about these. That's how you're developing also. Sorry, well, yeah, nothing major to result to report on East, other than I was just going to point out the work that's being done on the payments. Consultation is still ongoing. There was a briefing yesterday. As we know, this does very much looking at current usage and any unmet need and how to
reorganise the capacity across Wales. The options generally look at Powys and the North Wales elements of the service, but there are implications in the South East as well. So there's some further work being done on that. So I'm sure we need to pick up a later date. Okay, any questions on that? No? I was just thought, just to note that all the work that's going on around changing this from the 1st of April, we won't have a WISC or a National Commissioning Collaborative Unit in its current form. We will have a new National Commissioning NHS Wales Road Commissioning Committee. That's the one. I thought you've got to look around because I'll say the wrong authority. But it's changed today. So there's a huge amount of work at the minute going into, which as we said, Rani is supported by the government. All the support and leaders doing a brilliant job. According to commending her work, and she's fortunately trying to stick to the trick. But so this will change going into next year. And great credit was attributed by the chair nominee to the oversight board, which has been led by Welsh Government yesterday, about the sterling work that Rani's been leading in looking at the effective governance of the future, which is really important as far as we're concerned, and how the health system is going to be held to account. So it was nice to hear that acknowledged in the chair's meeting. Lovely, thank you. Right, now the issues from the committees of the board. Anything new?
Yeah, for a change, I'll bring up a couple of things.
Okay.
To which we touched upon already. One is whistleblowing. I mentioned earlier that we are looking at bringing in whistleblowing.
Yeah.
The scope in which we're still discussing. They will have time to do. The second piece there, elections. As of a couple of days ago, we've got 64 actions that are outstanding, not outstanding, sorry, are overdue from where they were agreed originally. 34 of which are beyond their actual delivery date and haven't been reviewed. So those we are looking at people. So I would hope to get the board support to encourage people to look at the dates on these and address them. And then we've got another 30 items that were beyond the original delivery date but have been pushed back. So a couple of them we've mentioned already today, which are the health and safety ones from 2000. Some of these are quite outstanding. So we'll say if I can encourage people to have a look at some of those items.
Thank you.
Because obviously once the internal auditors come back to relook at these, the actual grades of the audits are impacted quite dramatically by any outstanding ones from the last time we looked at them.
Thank you, Ian. So if we can all do that, because that's requested. Patient quality.
Just two things very briefly. One is just around infection control, just to confirm that on the 11th of October we did have a deep dive and we're going to follow that up. And just as a matter to note, the All Wales QPS chairs peer group has requested Jenny to come and tell them how we do our papers for PQSO, because apparently we do the best than anybody else. So it's been a request for the style that we're using to be shared, which I think is correct.
Okay. Any questions to Pippa? No. People and culture, Louise?
Yeah, thank you, Chair. Just to let you know that the quality of sound my end is very poor, so I hope you can you hear me?
Yes.
Yeah. Okay. Okay. So there's two matters that we were going to raise, or I was going to raise with board. It's the suspensions over 4 months, as we're bound to report anything over 4 months, and then it's the 2p transfers that we were going to highlight on as well. But hopefully Sarah can give some more feedback about that, if that's okay. Thank you.
Thank you. 2p transfers. There are a number of 2p transfers in progress. There is one which is ongoing but delayed. I think previously spoken about the trams project. That's a pharmacy related project in terms of shared services or Wales solution. There's delays concerned with that in terms of the service model. So there's no implications for our staff immediately. There are transfers in terms of vascular services and Tredegar Health Centre, and also one member of the research and development team. And the HR team involved in providing expert guidance and support in terms of those complex TUPE transfers. And in terms of the suspensions, just to note that the ones which are longer term are involved in complex investigations, including safeguarding and police involvement. A question? Population health and planning. We've already brought the vaccination risk to the committee. The only other thing to note is that we received a report on regional planning, which is proceeding, but we were very concerned about receiving an update on the quantified effects of service delivery delays associated with delays of digital projects being implemented, and that should be requested from DHCW for the next meeting. Thank you. Okay. Shared services partnership, Sarah. Just two things to pick up which will have an impact for us potentially from a financial position is around the different way agreed in terms of supply and energy, which would be advantageous for us. And also there's been a new methodology in calculating how we share costs for the Welsh risk pool that may have a negative impact for us because it's based on proportionality. But my understanding is that directors of finance have been involved in this. Thank you. Any questions to Sarah? Okay. Is there any other business? No. Well, the date of the next meeting is the 24th of January. And we shall now go into our in-committee meeting. Thank you.